now than it was, just 5, 6 years ago. Or 3 years, yeah, well.
Okay.
But still, I just, yeah, I can't remember. It's been my life.
I think
Are we ready?
we are ready. Yep.
Okay,
Okay, Doug's online.
I think we're going to go ahead and. Okay, we're gonna go ahead and get started.
Yep.
So, good morning and welcome. And happy to have you all here. I'm gonna go around and do some introductions, but Mary Ann Lindblad, board chair, and turn it over to Eileen.
Eileen Cody, board member. Hong Chuang, board member.
And staff.
Simon Borman, HCA staff member.
Michael Tunick, Assistant Attorney General and Legal Counsel Board.
Mike Neuschwander, the manager for the PDAB program here with HCA.
And I'm Ryan Bister, SCMD, Assistant Chief Pharmacy Officer here at Healthcare Authority.
And we have one board member online on Zoom. Douglas, do you want to introduce yourself?
Hi everyone, Douglas Barthel, board member.
Well,
Just a minute.
no volume here.
Oh, okay. I can hear you okay. So just let me know. And looks like my
Not on mute.
microphone is working, so.
Still don't hear you.
Zoom gremlins.
I've had to get on twice lately off of.
Oh,
because
yeah.
the thing hasn't been working.
It's early, maybe it's still asleep.
Okay, over.
1 minute while we work through some technical difficulties here.
We'll just see if Kelly comes off, if you can hear her.
Kelly, can you
Yeah.
can you test and see if we can hear you?
Can you hear me?
Nope.
No,
It's on our end.
it's on our end, okay.
Kelly, can you hear me?
All right, so we'll have a
Okay.
couple
Yeah, I can
minutes
hear you.
here while we're waiting to
Okay, I can hear you as well, Kelly.
With our speakers.
some technical difficulties.
Lonnie's got his hand raised.
Yeah.
Never met him. Oh, you haven't? No, but we spoke on it.
Okay, so yeah, it sounds like Marina can hear everyone, so it must be our speakers on this side.
Yeah. Okay.
That gives us a better chance.
I've asked them.
Right, troubleshooting.
Nice.
Updated, yeah.
Kelly, can you hear us?
Yeah, I can hear
Can
you.
you try speaking now?
Yeah, I'm speaking.
No,
No, still can't hear.
I'm safety, I'm not IT.
Oh,
Masquerade.
yeah.
So maybe we just wait for the IT person to show up. Okay.
Yeah.
Yeah.
It's like, so,
10-minute break.
yeah.
Well, unless we could get like,
We could do.
but then not everyone would be able to hear.
Yeah.
Yeah.
Time's sake, go ahead and have Mike do his report.
Okay,
And, because everybody can listen in on that.
okay,
We'll catch the rest of the introductions.
sounds good. Yeah, then we'll go back and before we do the presentations, make sure we get everyone online. So that way we can ask questions.
They can hear okay, right?
Yeah, I believe they can hear
Yeah,
us
sure.
just fine. Okay.
Good idea.
Okey doke, switching gears. Yeah, thank you very much. So some of the things I wanted to chat about a little bit are just some updates as we've been looking out for the next year on our program of work and what we were doing. We've been talking and working together as a team, trying to see how we're gonna stack and allocate our work over the next few board meetings. And so I just wanted to go with a rough outline here of kind of our path or our vision forward, and what we were hoping to do. So today's meeting, we'll be talking about our policies, our potential policies for creating our drug list, and also discussing our drug selection methodology. Porter will be talking to us about the drug reviews and some of the things that we need to consider. Moving on into July, we'll vote on our drug list methodology. So today's the policy we'll be going over, and we'll be approving or voting on that, how we create the list in July. We'll also continue discussion on our prioritization methodology. So once we get the list, how are we going to sort all of these drugs and decide what to choose, and potential data measures that could be used to narrow down that list. Other things we'll also need to look at are if we want to make any changes to the WAC, Washington Administrative Code, as well as begin looking at our ledge report, because we have that report due in December every year. Those reports do take a little while to put together, so just begin discussions on that. Then as we move through the summer of 2024, we'll be looking at our advisory group applications. I know we talked about the advisory groups and how we were wanting to set that up at our last meeting, and also what candidates may have applied. So we've already been talking to our pledge team and any people that they feel might be able to help us on those advisory groups. But if the board members have any other people that they think would be good candidates, we can work with Simon to make sure that those candidates get the application and are able to fill that out. And then also we'll have the board start looking at our weighting of our metrics for the drug selection methodology. Then in September, we can vote on the final methodology for prioritizing or selecting those drugs. And then we can also vote to appoint the advisory group members. Then in November, we can present the list of our prioritized, the prioritized list of the drugs for the board approval. And we can also begin discussions of what drugs we possibly might want to select for that. And in December, get the advisory group input on the drug selection. And then January shortlist those drugs that we've been talking about. Then March vote on the drugs that we want to select for the affordability review. So any questions on that general timeline and update? And all of this is, again, we're trying to be flexible as needs change, or maybe we need to look into something or do something.
Doug just had something on about sharing a copy of that.
Yes, I'll do that. So that is our general timeline. And looks like we got our IT support here. So we can do a short pause here while he looks at the speakers. Kelly, if you could speak.
Testing, 1, 2, 3.
There we go.
So it's gonna be very similar, it's gonna be the same administrators.
Did it work?
Well.
Yeah, we can hear you now. It's a little
Great.
soft, but we'll work on it. Volume.
Just curious.
Talk again.
Yeah, at least finance.
Yep. Talking now.
Go ahead, Doug, one more time.
Testing, 1, 2, 3.
That's fine. We can hear.
I know I should be paying more attention to that.
I mean, it's. We just, set a file.
Yeah.
CMS, like with their approval. I mean, you obviously can talk to Dave. But, yeah.
It's the game not calling, but it's like on the other end, I get going. I should be.
Well, the board meetings haven't done it as much. 'Cause
Oh, they
we
haven't
did
been at
We
this
did it
point.
more. One more time.
Okay.
So we are now looking at some of the other benefits.
Say one more thing, Doug.
Yep. Hello, testing.
I mean, you can imagine I have so many friends that talk. What are they doing about that?
Yeah.
Well, I'm not concerned so much, but I think just understanding it.
It's-
Because I know one of my really dear friends who's been a state employee for.
Yeah, it's just in the back.
No, no, she retired one of those in first one, and so they're pretty young.
One more time, Doug.
And,
Yep. Testing.
Medicare is, having you.
Yeah, I think we're good. Okay,
That's what we're hoping.
Yeah, and get a better.
Right, and also better rebate.
Well, yeah, that's true too. All right,
Hey. yeah.
okay, we're on.
If
So
we're back in
now
business.
can you introduce yourself?
Yes. I'm Douglas Barthold. I'm a board member. Nice to see you all.
Welcome. So back, we need to introduce staff.
Yeah,
Let's go around and introduce staff and start with Kelly.
Stepped away.
Yeah, okay, well,
Oh, hey, I'm Kelly and I'm the PDAB data analyst.
and
Marina.
Marina.
Hi, this is Marina. I'm a health economics research manager.
And maybe Jinping is the last one.
And Jinping, okay, and Jing,
Hi, this is Jinping. I'm the cost and quality analytics manager.
great.
I think Donna's online as
Oh,
well.
is Donna, are you online?
Yeah, hi, this was Donna Sullivan, Chief Pharmacy Officer. Sorry, my camera's not working, so I'm not on camera.
All right.
Okay.
So Mike, do you have anyone else?
No, I think that probably should be it. So yeah, Donna signed in under my name there, so
Oh,
uh,
that's what you're.
when it says Mike,
That's
it's
twice.
not Mike, it's I'm Mike, so.
Wait, all right. Well, now we know why. Well, should we just go ahead then, and with the portal presentation from Dr. Rome? Are we ready for that, or do you have
Not
more?
quite, I have one more
thing.
little thing I
All right.
wanted to chat about, and then we can make sure, see if portal's online here.
Okay.
So the last piece, is just a short legal update, on some of the things that are happening with other PDABs around the country. So the Colorado, Prescription Drug Affordability Board did have a lawsuit filed against it by Amgen. The lawsuit stems from the board's decision in February of this year to label Amgen's drug Enbrel unaffordable for patients in Colorado. Enbrel is used to treat rheumatoid arthritis and other conditions. The plaintiffs argue that a Colorado law establishing a Prescription Drug Affordability Board violates the due process clause of the 14th Amendment, as well as the dormant commerce clause, and is preempted by federal patent laws, federal laws concerning Medicare and other federal health programs. So I know there's some online articles about it that go into more detail. To do a brief update of some things that are happening with the other PDABs. And so any general questions about that from the board members?
They've got are there two different states now that have lawsuits?
Uh,
Colorado, and is there one more?
Yeah, and then Oregon has had a lawsuit filed against their drug price transparency program as well. So two separate programs in two separate states, but they are related in a number of ways.
Yeah, I just have a question, and I don't know if any of us have the answer to this, but are there any examples of states regulating prices for anything that has a federal patent?
That's, people are looking at me. Why I'm speaking, Doug, is that that's not a question I've thought about, so I can get back to you on that if that's all right, but I think it's not something that I've thought about, but that is a very good question, yeah.
Probably not on the state level. I mean, the Inflation Reduction Act has some pricing mechanism in the so, and that's still working its way out.
Yeah, I mean, I'm obviously not a lawyer, but it'd be interesting to see, because that presumably violates the same patent restriction, but at least that has a federal law behind it. Ours only has a state law behind it, so I don't know what the if that makes a difference, but.
Any other questions?
Anything? No. Anything else, Mike?
No, that's it for me.
All right. So are ready for the portal
Portal will be joining at 9.
at 9.
9 o'clock,
Okay, so
right,
we've
minutes.
got a few minutes. All right. No? Anything any questions that any folks want to talk about or kill time? What did you do on your summer vacation? Or what are you going to do on your summer vacation?
Yeah, I was gonna say, it's not summer yet.
Not yet.
Yeah, maybe we can
Should we just do a
do a
break?
short 5-minute break here.
Well, if it's entertaining.
If it's
So it's, yeah, it's a friendly, so Mike, you rattled through kind of like the next 6, 8, 9 months, kind of like what you're gonna do at each meeting. And you were talking so fast, I don't think I got it all down. So I was wondering if you might want to just repeat that.
Oh, sure. Can do that. Right now in this meeting, we're discussing the drug list, developing that list and the policy behind developing that list. And also beginning discussions on drug selection. So once we get the list, how do we select from that list? In July, We'll continue our discussions on the prioritization of that selection, and potential data measures that can be used to narrow down that list. We'll also vote on our drug policy or on our policy creating the drug list. And then also be looking at any changes we need to make to the WAC, as well as a ledge report that's due by December. Begin discussions on that. Throughout summer of 2024. Begin looking at the advisory group applications and the candidates that applied for that. And then also having the board members looking at weighting metrics for the drug selection, and how they might want to do that. And again, if the board members have anyone for the advisory groups that they think would be a good fit, work with Simon, that way we can reach out and get them an application. September, then having the board vote on that final selection slash prioritization methodology. And also working to appoint the advisory group members from the applicants that we have. Then in November, presenting that prioritized drug list for the board. And also continue discussions on like the selection from that prioritized list of what we want to do. And in December, get advisory group input on that list. And in January, create the short list of drugs for the affordability review, and March vote on the list of drugs that we want to have for affordability review. Yep. Yep.
Thanks. Any other questions? Anything else? All right, well, I guess we just have a 5-minute break then, and we'll be ready for the portal conversation.
Yeah, how are you? State of Alaska?
We're going to-
Yes, I think it's their pharmacy director, Aaron.
And I think the day I reached early. So no.
Yeah, we're gonna do that.
I'd really be interested.
Change it.
And we-
Medicaid,
We've going to talk about doing it, and
So they
outsource to, so, but last night, I bought this.
they check us
Mile poster,
and
which like
then
describes every mile, you know.
it was first it was Xerox.
Yeah.
Need the paperback, right?
Oh, God, I need that one. We took pictures of it. Are we ready, Mike? So, all right, guys, we're gonna get back. All right. So, gonna go ahead with the portal presentation. So I want to turn this over to Dr. Rome. You want to introduce himself, and then we'll go ahead with the presentation. So, what happened?
Hi, all. Can you hear?
Oh, there you are.
Great. Good to see everyone again. I'm Ben Rome. I'm a primary care internist and health policy researcher in the Program on Regulation, Therapeutics, and Law, or Portal, based at Brigham and Women's Hospital and Harvard Medical School. Matt Martin, our program coordinator, is also here today. Together, we've been doing a lot of work with our team on PDAB. So good to be back and sort of talking more about this. So we're going to kind of run through some issues around sort of actually conducting affordability reviews, or sort of thinking about how to assess affordability of drugs. Matt, do you want to kick things off with slides?
Absolutely.
And then I'll take over partway through.
Yeah, sounds great. So so the focus of the conversation today is kind of looking ahead down the road a little bit, and focusing on sort of considerations for conducting affordability reviews. Let me share my screen. Slides up. There we go. Are the slides showing up on everyone's on the other side?
Yep, you see it.
Perfect. Great. So to sort of start the conversation, just wanted to sort of disclose that Portal as a group we don't receive any funding from pharmaceutical or medical device companies, and you can see the list of funding sources that support our research on the slide here. So an outline of sort of the conversation today, want to sort of start out with an overview of sort of the PDAB process and sort of where you are, and then sort of where we will be focusing for the remainder of the presentation. And then Ben and I will sort of talk about some considerations for you all as a board as you're moving through the affordability reviews, and how you can sort of assess and define what affordability may mean to you all when you're selecting drugs and reviewing them. So to start out with a bit of an overview to things, so this is a familiar slide that I think we shared our last presentation, but we kind of consider the PDAB process in 4 general phases. So you all have been really focusing on the first 2. So as of right now, so identifying drugs that are eligible based on statutory criteria and developing methodologies to identify those drugs, and then thinking through based on other sets of criteria and data points to select which drugs you think you'd like to review for the current sort of affordability review cycle. And so what we kind of want to focus on today is the next step in the process. So looking ahead at the affordability review itself. This is really going to be the sort of most intensive component of the work that the PDAB does. And we want to particularly focus on the charge you all are tasked with at the end of the affordability review, and making assessments of whether or not a drug that you've selected has led or will lead to excess cost to patients in the state. We want to provide some sort of some framing around that decision, and how the different components of the affordability review and framing them in the appropriate way can help you reach a conclusion in as easy a way and as comprehensive a way and thoughtful a way as possible. So in reviewing the statutes and rules that sort of dictate the affordability review process for the board, there's sort of 2 sets of factors. There's first the one set that are sort of the core components that you all statutorily will consider as part of your process. And the key thing to keep in mind here too is that during the affordability review, you're going to be presented a lot more data and information about the drugs you've selected than you may be receiving and reviewing earlier on in the process when it comes to the drug selection phase. So knowing that once you select a drug, there will be a lot more information at your disposal to make a thoughtful assessment of that drug's affordability in the state. And so you sort of see on the various components that are listed here, we're going to touch on high level some of them later on in the presentation and are happy to sort of do deeper dives on individual components in future presentations. But components around sort of the price of the drug, the out-of-pocket costs that patients may face for the drug, the existence of patient assistance programs, how decisions like formulary placement and other sort of PBM-related policies may affect access to the drug and utilization of the drug, comparing the drug with its therapeutic alternatives, what their prices are, what their clinical effectiveness is relative to the drug that's under review. And then additionally, looking at and taking into consideration input from a variety of stakeholders who you'll be engaging with throughout the process. So that includes patients, individuals with medical and scientific expertise that may be particularly relevant to the drugs themselves, and other materials that the manufacturer and payers and other entities and advocates may submit as you could do the review. There's then a sort of in statute, a second set of factors that may provide additional context to the board as you assess the affordability of drugs. So you can see these here. They kind of vary in the sort of scope that they focus on, but this could be things like the availability of biosimilars or generics for brand name products, or the average cost of the drug in the state, the revenue that the manufacturer reports for the drugs that are being reviewed, off-label uses of the drug that may be beyond the FDA-approved indication. And then importantly, you also have the ability to identify additional factors that may be relevant, that perhaps when you're looking at drugs at the identification and selection phase, there may be data elements that aren't in this sort of set list that may provide additional context that may be important for you all as you move through the review. So with all these different data components, the sort of central challenge then becomes, how do you take all of this information from a variety of sources and from a variety of stakeholders and sort of funnel it down into a final determination of whether the drug creates excess costs to patients? And so there's a lot of different ways you can think about this, but we kind of want to present a framework that highlights 3 different perspectives that you can use to assess the affordability of drugs to help analyze all of these different information and all this different information and data points in a way that's comprehensive and that also allows you to reach a conclusion and a consensus as a board. Which brings us to the sort of next part, which is an overview of the sort of framework that we've put forward. I also will add that at the end of this presentation, we've linked to the white paper on this topic that goes into a lot more detail on the specific elements of affordability reviews and some of the more technical and data items. So that's there as a reference, and I'm happy to share that more broadly as well. So to sort of get at defining affordability, I think we first sort of turned to the statutory language that you all have been given when it comes to excess costs. So as I mentioned previously, you are tasked with assessing at the end of the affordability review whether a drug has led or will lead to, quote, excess costs to patients in the state. When you look at how excess costs are defined, there's sort of 2 pathways you can look at excess costs. So you can look at excess cost as those the cost of the drug exceed the therapeutic benefit relative to other alternative treatments. So that could be in class, in the same therapeutic class, or more broadly, depending on the priorities of the board. And or you can think of excess costs as the costs of the drug that are not sustainable to the public and private healthcare system over a 10-year timeframe. So this is the more system level approach and thinking of costs. The other component here is that it's excess cost to patients. And we touched on, I believe Ben touched on in his last presentation, it's important to also think about which patients you're considering in this process. Is it cost to the patients who are only those taking the drug that's under review, or is it more broadly thinking about all patients in the state who may be paying directly or indirectly for some of those costs of the drug, and the sort of budgetary trade-offs that may result for all patients who sort of face the financial impacts of these drugs. And so with this framework in mind, we then sort of proposed in the white paper, and then we'll sort of highlight in more detail here, three different perspectives that you can use to think about the affordability of a drug. So in sort of one angle, you can look at the cost relative to therapeutic alternatives. So this may be situations where the drug, the clinical benefit that the drug adds may not be in alignment with its cost when you compare it to other similar treatments that may treat the same disease or condition. The sort of second perspective is thinking more targeted on the out-of-pocket costs that patients face. So there may be drugs that out there for which there is clinical value and added benefit relative to alternatives, but that patients still nonetheless face significant financial burdens in accessing those drugs in the state. And then the third perspective here is going back to that sort of budgetary consideration. Are there drugs that may be cost effective, they may have added benefit, but nonetheless, they pose a financial risk to the overall state healthcare system, which can result in increased healthcare premiums for all patients and consumers in the state, and also result in require budgetary trade-offs that may impact other areas of spending within Washington. And so while we sort of highlight each of these perspectives as sort of distinct pathways, I think it's important to consider each of them during the review process and not just sort of focus on one individual component, because by taking some of these different perspectives into consideration, you can sort of emerge with a more well-rounded view of this drug that's under selection, particularly because some of the data elements that you may be exploring and examining may be telling different stories when looked through each of these different perspectives. And so it's important to sort of look at it as comprehensively as possible so that you can come to a determination that really represents as close as feasibly possible to the reality of this drug's access and affordability within the state. And I think I'm going to turn over to Ben now, who's going to dive a little bit more in detail on the different components that fit into each of these different perspectives on affordability.
Great, thanks, Matt. And you know, the way these slides are set up, we're going to talk about sort of each of these three sort of buckets of ways of thinking about things. And on the right-hand side, we've listed some of those factors that are sort of specifically listed in statute and rule within Washington, of sort of how those factors can sort of be bundled and sort of actually used, come out in each of these buckets, because, you know, otherwise you just sort of have a list of factors that are being considered. So the idea of sort of putting things into these categories allows you to think about sort of what is the meaning of all that information when combined together. So first, the first up is the cost of drugs relative to therapeutic alternatives. And so for many drugs, the added clinical benefit that the drug provides may not align with its cost when compared to treatments for the same disease or condition. These would be sort of therapeutic alternatives for the drug. You know, importantly, a lot of drugs have multiple different indications, so you might have to analyze, you know, the added clinical benefit separately for each indication to sort of make a determination. We know from lots of prior research and other international assessments that many new drugs that come to market do not offer substantial clinical benefits over existing treatments. That's maybe second-in-class products or drugs where the evidence hasn't really actually, you know, may support that it's effective, but it hasn't actually been tested against sort of existing lines of treatment to see if it's more effective than what's already out there. And that can be a very powerful way to sort of think about sort of if you have two drugs that treat the same condition and you have no evidence that one or the other is better, say, for more effective, maybe we ought to pay the same for those two treatments. If you go to the next slide, Matt. So how do you define, you know, therapeutic alternatives? I think this is an important sort of step in the process for making these determinations. I think it's really important to think that therapeutic alternatives are not necessarily going to be identical in terms of safety, efficacy, mode of delivery. By mode of delivery, I mean, you know, an injected product versus an oral drug, right? They might be sort of different ways of administering the treatments. There might be, you know, small differences in the safety profiles or even in effectiveness. And it also doesn't mean that products are interchangeable for patients. And I think it's very important that the board sets up this expectation if you're going to select therapeutic alternatives for drugs up front, because, you know, obviously for an individual patient, there might be factors to consider. For one reason or another, one drug may or may not be a better choice. But when you're looking at this on a population level, right, the question again is sort of like, is drug A really on a population level better than drug B? And if not, then why should we pay more for drug A? How the board defines therapeutic alternatives really is going to, you know, should be informed by how you plan to use the therapeutic alternatives as part of the review. And there's a range of options. Sort of on one end, you could sort of narrowly define drugs that are within the same pharmacologic class. So, for example, TNF inhibitors, right? So all drugs that affect the specific, like the TNF inhibitor pathway would be a small subset of drugs. They would be very similar in general, used for the same indications. Or you could take a broader look at indications. Sort of you could look at all drugs that treat a particular condition across multiple different disease classes. You could even expand beyond drugs to think about devices or surgical procedures or other types of interventions that could also be used in those particular conditions. And so obviously taking that broader definition might give you a bigger bucket of comparators, which, and maybe the prices for those comparators are going to vary more, right? So within a pharmacological class, you might expect a little bit less variability in price. And so it's not going to be as powerful a tool. But obviously, the broader you get, the more challenges you get in actually defining sort of what counts and what doesn't count as a therapeutic alternative, because there's more variability in those products. On the next slide, the last piece here is just to really point out that there's a big difference between comparative effectiveness and economic analysis. And both of these are tools that can be used to compare drugs to therapeutic alternatives. On the comparative effectiveness side, you're really just focused on the drug's effectiveness, safety, and ease of use relative to therapeutic alternatives. And the ways you can look at that information is pre- and post-market clinical trial data that's conducted by manufacturers and often submitted to the FDA and made publicly available. There are, in some cases, are direct comparative effectiveness trials comparing one drug to another, though oftentimes there aren't head-to-head trials. There's a bunch of placebo-controlled trials, and you may have meta-analyses that try to combine that information and make indirect comparisons between different drugs. In some cases, you have real-world evidence or observational studies of patients who have actually used different drugs. International health technology assessments often combine these data, sometimes perform their own meta-analyses, and make assessments about sort of the relative benefits, net benefits of all these factors of different drugs. So many countries do those types of assessments. Again, this is without cost, just considering how well does the drug work or how much does it benefit patients. And then obviously you want to take input from patients and experts to make sure you're thinking about this correctly when you're doing these types of comparisons. In terms of the economic pieces, when you add cost into the picture, now you're sort of asking questions about what's the incremental cost versus the incremental benefit of a drug, compared to a therapeutic alternative. There always has to be some sort of comparison. For drugs without a lot of therapeutic alternatives, many times the comparison will be, standard of care or no treatment, but you have to compare to something. Traditionally, cost effectiveness analysis is this type of model where you measure this. And in modeling studies, you look at the long-term cost of a treatment and sort of how much that's going to cost for patients to be on that treatment over time. You model out the cost if the patient's not on the treatment or if they're on some alternative treatment, and look at that. And then you compare that to sort of some measure of how well the patient is doing, how long they're living over time. Efficiency frontiers are an alternative approach. I think we talked about this last time, where you can sort of map the cost and effectiveness, sort of net benefits of each drug on a plot, and then sort of use, look at which ones are more costly or sort of less costly and more effective to find the ones that are the most cost effective. There's often published literature of cost effectiveness trials for different drugs, different conditions. The Institute for Clinical and Economic Review, or ICER, publishes reviews or analyses in a lot of different clinical areas. And obviously, other countries do this work as part of their health technology assessment to, just to make decisions around reimbursement and price negotiation. And components of those may be helpful when sort of looking at some of these judgments. But again, just keeping in mind that you can do comparative effectiveness analysis, you can sort of think about drugs compared to therapeutic alternatives without actually looking at cost. On the next slide, we're going to turn now to sort of bucket number 2. This is patient out-of-pocket costs. So, again, this is drugs that are clinically effective, yet maybe patients face significant financial barriers to accessing the drug, and this can have important implications for medication adherence and clinical outcomes. And I think when you ask patients, is a drug affordable, their gut reaction is to think about this, right? When I show up at the pharmacy counter, how much am I going to pay, and am I going to be able to pay that much to actually get the drug? When people talk about people not filling insulin and other medicines, this is typically what individuals are talking about. And there's a number of factors that you're required to think about that fall into this bucket. So how do you inform this perspective? I think there's a number of different data elements that you're going to want to consider. First is just data from all payer claims about what the average patient is paying out of pocket for the drug. Now, importantly, there's limitations to this, right? You don't capture patients who don't take the drug because of cost. So you only capture people who actually fill the medicine and take it for some period of time. But it still provides an important set of real data on sort of what the experiences are of patients. Second is insurance coverage. So how well covered, how accessible is the drug to patients who have private insurance, Medicare, Medicaid, other types of insurance? Is it included on the formulary? What tier is it on? Are there utilization management tools like step therapy or prior authorization that sort of restrict access depending on certain rules? Third is how manufacturer rebates affect coinsurance and deductibles. So many of you are probably aware that generally when drug companies want to offer discounts on drugs, they do that through confidential rebates, and the patient out-of-pocket costs can still be based on the high kind of price for a drug. So if you have a drug that's priced very, very high, but has substantial rebates, out-of-pocket costs can actually be high proportional to the total cost of the drug that's incurred by the healthcare system. And finally, manufacturer assistance, co-payment cards, patient assistance programs. Importantly, these are not going to be reflected when you look at claims data, right? So if a patient uses some other means, including manufacturer assistance, to pay for their portion of the out-of-pocket expenses, the insurer is not sort of aware of that, right? The insurer says you owe 25%, but if some of that 25% is covered by the manufacturer, you're not going to see that in traditional claims data. There are data sources where you get pharmacy level data that you can see sort of how much a patient is actually paying, but those are not going to be in sort of your traditional all payer claims database. And also it's important to think about health equity and obviously engage patient stakeholders to solicit feedback about what patient experience is for these drugs. On the next slide, just a couple pieces here. So on insurance coverage, there in terms of how do you get data on this, it can be challenging to sort of collect all the information from many different insurance plans. There is a company, MMIT, that has a database that does this. They make kind of a easy to access version of their data available on an app called Coverage. So here we just ran Eliquis in the state of Washington, so you can sort of see what this looks like. You can see that coverage of the drug is in general pretty good. It varies a little bit between commercial, Medicare, health exchange, and Medicaid. And you can see that you can see whether drugs are on the preferred sort of status, which is sort of easily available generally with no prior authorization, or whether there's impositions imposed for patients to get the drug, or whether it's not covered at all. So this could just be a helpful framework, I think, to look through around access. And on the next slide, we talked just about manufacturer assistance programs, just to differentiate between co-payment cards and patient assistance programs, because this is going to come up as you start to think about these things. You can find information about these from manufacturers, right? So even if it's not in the data, you can see what programs are available. Co-payment cards typically are, they typically offer patients to lower the cost to less than $30 a month, often $5, $10 a month. Regardless of what the insurance is going to charge, but they often have monthly and annual limits. So if a patient has a high deductible plan, it might not cover their full cost for those first 2 months while they're in their deductible. And the programs can vary year by year, or they can go away completely if the manufacturer chooses to sunset them. They're only available to patients with private insurance, not people with Medicare, not available to people with Medicaid as well, although patients on Medicaid typically don't have high out-of-pocket costs. And there's no income or asset criteria. So anyone can just go on the manufacturer's website and sign up to get one of these cards in general, as long as they meet the eligibility criteria in terms of their insurance coverage and state and things like that. So these are commonly used for many types of drugs. In some studies, up to like 25% or more of patients in commercial insurance plans will use these for particular high cost drugs. So they are highly used, although they can change over time and go away. Patient assistance programs, by contrast, have strict financial eligibility criteria and lengthy and onerous application processes. So patients have to submit a lot of data to the drug manufacturer to determine whether they qualified. And I've personally had patients who've been hesitant to go through that process. And it's also just onerous on both the patient and on the doctor, who has to fill out a lot of clinical information as well. So the use of them is more limited because they don't apply to all patients, and they're really targeted towards people with low means. But these can can include people in some cases on Medicare as well as commercial insurance. All right, and then the final bucket of these three is sort of thinking about the budgetary impact on the state. Here, you're not just looking at how much patients are going to pay or whether patients can access the drug, but just the broader impact on the healthcare system. So this is, even though drugs might be cost effective at their current price or even sort of aligned with other products, they could still pose financial risk to the broader healthcare system or the state healthcare system. And this can impact insurance premiums for all patients and can also require other budgetary trade-offs, right? So state spending on prescription drugs through Medicaid and through state-sponsored insurance goes up, then maybe you have less money to spend on education, roads, other things that the state needs to spend money on. There's some good examples of drugs in the past decade that have kind of met this kind of criteria where maybe the budgetary impact is the main concern. So hepatitis C antivirals were deemed cost effective by academics. Even at the initial price point, they were priced around $100,000 per course of treatment initially. And even at that price point, because they were so effective curative treatments that prevented the downstream complications of cirrhosis and downstream complications of hepatitis C, they were cost effective. But so many patients had hepatitis C and the cost was just so high that the system couldn't absorb those costs. And therefore, state Medicaid programs and many other insurers imposed really strict regulations on who could access the treatments, which limited their public health impact. I think GLP-1 receptor agonists for obesity and diabetes are sort of the kind of modern example of this, where they are highly effective drugs. Nobody would argue that these are drugs that shouldn't be used to reduce cardiovascular risk in patients with diabetes and obesity. But they're expensive, and the prevalence of diabetes and obesity is just so enormous that it's gonna raise constraints. And we're seeing private insurers make trade-offs, decisions about sort of whether to include these drugs on the formulary or not, because doing so would mean that they'd have to raise premiums substantially. So how do you inform this perspective? You can look at formal budget impact analyses. You can either conduct these yourself or sort of look at ones in the literature. In general, budget impact is focused on a more shorter time horizon than a cost effectiveness study. You're looking at like a 3 to 5 year window, and you're not looking at outcomes. You're just looking at sort of cost. So how much it costs for the drug based on how people use it, minus any savings maybe from fewer hospitalizations if the drug leads to fewer hospitalizations. These analyses are typically done when drugs are first approved, and so it can be a little more challenging to do the analysis once a drug's already on the market. You can also look at state level spending estimates on the drug. I think that'll be sort of easily accessible data to you, and solicit input from payers and PBMs, because they're the ones who are going to know which of the drugs are really straining their system, which are the ones that are at the top of their priority list in terms of making it difficult for them to set premiums each year. So there's going to be information on sort of which drugs sort of meet this threshold, even if you don't have formal budgetary kind of assessment data. On the next slide, I think this goes back to sort of how Matt framed this at the beginning. Incorporating data from each of these three perspectives is going to be useful to ensure that you have an affordability review process that's robust to a variety of drugs, right? There are many different, there's a lot of drugs that are going to be eligible for the process, and you want to be able to sort of understand what the tensions are for each individual drugs. And you're going to have to balance complex and in some cases contrasting information. As we just said, you can have drugs that are extremely effective, extremely cost effective, but are posing strains to the system nonetheless. So you can use all that to arrive at your sort of ultimate decision around whether drugs create excess costs to patients. So hopefully this is helpful. If you're interested in sort of we lay out these three frameworks and some additional data considerations in a white paper. Matt, if you go to the next slide, I think the white paper was published by our team in collaboration with NASHP, the National Academy for State Health Policy, and it was made available on NASHP's website earlier this year through our collaboration. So you can sort of see and read more about these considerations. So we hopefully have time for some questions and answers. Happy to sort of talk more about the specific data considerations as you all are thinking about moving ahead with this process.
Thank you. This was a great presentation. Do we have any board members with questions? Other questions from others?
I have a question.
Go ahead.
Okay, thanks. Thanks a lot, Ben and Matt. I think we met a few years ago. Nice to see you again. Yeah, so I just have a few questions regarding your some of these general recommendations, and also how these recommendations also fit in with the methodology for selecting eligible drugs. And one of the things that I'm kind of most interested in right now is the definition of a drug and whether you do that at an indication specific level. My understanding is that if you do it at an indication specific level, that would be very important for how you define the length of a course of treatment. It'll be very important for how you define therapeutic alternatives, also orphan drug status. So in my mind, all of those things also apply to the stage we're at right now, where we're selecting this list of eligible drugs. I was wondering if you could comment on that a little bit to just tell us about if you agree that that is important at the stage we're at right now, and if there are other implications of that choice aside from the three that I mentioned: course of treatment, therapeutic alternatives, and orphan drug status.
Yeah, I think it's a good point. I think I think certainly when you're assessing drugs, cost effectiveness, or you're going to have to do that for different indications, right? Because the use is going to vary. Even the budget impact for different indications might vary. In terms of the selection question of should you select only certain indications for certain drugs, I've never seen sort of heard any considerations about states or others doing that, and I think it poses some logistic barriers in terms of how you define indications. It always seems nice, neat, and easy to do that, but I'm thinking of cancer drugs where I look at labels where they're just like 20 or 30 indications, and some of them, could be bundled together to call like multiple myeloma or some other condition, but it's like first line or second line treatment. And, those considerations are really important as part of the affordability review process to understand, different, cost effectiveness in different situations. I think it would be very logistically complex to do that at the selection stage. It seems like you ought to pick drugs where you have, some reason to question the drugs, some reason to believe that the drug is likely to be, unaffordable for a variety of reasons. And I think the one that's hardest to predict without sort of diving into the weeds is the therapeutic alternatives consideration, right? So it's easy to say we want to look at drugs because of our statute and because of our priorities where they're expensive relative to therapeutic alternatives. But defining therapeutic alternatives is challenging. You have to do it by indication. You have to look at a lot of literature to sort of make that assessment. So doing that for hundreds of drugs is probably infeasible. I think budget impact and out-of-pocket costs, like you can get some of that preliminary data up front to get a sense, I think, for all drugs as to which ones sort of stand out in terms of their out-of-pocket cost number, their coverage numbers, their sort of spending numbers. So those ones are easier to get, like to kind of pick a list where you're sort of moving towards the top of those numbers, if that makes sense.
Okay, thanks. Yeah, no, I agree. And so I guess from your perspective, you're thinking of it as like do less work to get look at fewer less complicated items on this initial set of large list of drugs, and then when you've narrowed it down further, then do the more complex steps of like defining therapeutic alternatives.
Right. It ends up being, these, health technology assessments done by other countries, and everybody, these are complex, resource intensive. And I think if you talk to other states that are sort of going about this, Maryland just announced which drugs it's going to do these reviews on. Colorado has already started doing reviews. Oregon has started doing reviews. It takes a lot of effort to pull all the necessary data elements to meet all your statutory criteria and to sort of get a nice flavor of sort of like what's real about the drug. So I think, again, you want to be judicious about sort of how you're thinking about those elements for a broader list of drugs for your staff and just for resource reasons.
Okay. Well, thanks. That's very helpful. I do have another question, but I don't know if I want to let the other board members if they want to have anything they want to ask.
Please go ahead.
Okay, so the other question is about, as again in all of these steps, the creating an eligible list and the affordability review, the degree to which we should be considering which types of plans we can actually regulate with the upper payment limit. And I actually still don't know the answer to this in Washington. I've been trying to figure out exactly the set of plans where the upper payment limit actually would apply. But let's assuming that we had that list and that information was clear. Should that be considered as we define this list of eligible drugs and conduct an affordability review? For example, if you do a budget impact analysis, do you only want to include the plans that would be subject to the upper payment limit, or do you include all the plans? Because do we care about all Washington taxpayers or just the ones paying premiums in these plans? So I was wondering if you could comment on that.
Yeah, I know it's also a very good question. I think, again, I'll defer to you and your kind of team about sort of what the implementation side of the UPLs would be. I would say Medicaid is the one that stands out as probably the most different from others. Even it's a state, it's obviously a state program, partial federal funded program. But the prices of drugs tend to be very different in Medicaid than in other places because they're calculated through a rebate structure at the federal level, and they're not negotiated. Whereas Medicare and commercial plans, there's negotiation that determines sort of what the net price of drugs is. So they tend to be close together. There's not a lot of evidence that they're very different. Prices are very different in Medicare versus the commercial market. Obviously, that might change if the IRA, has stricter negotiation on certain drugs. But Medicaid can be different. The population is obviously very different, and the out-of-pocket cost issues are less important, right? So it's more about coverage and what's on formulary. And Medicaid in general cannot take any drug that's participating in the rebate program off the formulary, with some rare exceptions, like obesity drugs are carved out. They're allowed to exclude those. But in general, it's a question of prior authorization and restrictions and step therapy and things that are prohibiting patients. Once patients can access a drug, in general, they pay very little or nothing to do it. And so it's not, the out-of-pocket costs are different, the prices of the drugs are different, so therefore the budgetary impact's different in Medicaid than it is in the other types. I think if you sort of remove Medicaid and bundle everything else together, I don't think you'd notice major differences in Medicare versus commercial. That said, there are certain drugs where they treat different populations differently. So for example, cancer drugs in general are going to be more predominant in the Medicare population, just because cancer in general is a disease of aging, right? And Medicare covers most people over 65. So the list of drugs, if you're looking at sort of spending, is going to be different between different populations, like commercial, Medicare, Medicaid. Those are the biggest three. Obviously, there's other smaller populations. Within commercial, there's state-sponsored insurance as well, which will probably look similar to a commercial population, but in many ways.
Okay, thanks. Yeah, that's very helpful. And so, I wouldn't expect anyone to really know this, but does anyone happen to know if the other states, Colorado or Maryland, have in the steps of their process separated by type of payer in their processes?
I know that Colorado, when they present out-of-pocket costs, both for decisions around in the affordability reviews they presented, and also in the step for selection, they calculated average out-of-pocket costs for non-Medicaid patients. So they excluded the Medicaid patients because many of them are zero in that calculation, because but they show the percent of, and they did show the distribution, the percent of patients and the percent of spending, I think, that was Medicaid. So I think that's on their dashboard. You can see sort of the breakdown of those three big buckets. So yes, other states have thought about sort of and I think if you listen to their sort of deliberations on those, I think it did come into play as to which categories of patients were most affected. So yeah, I think it's come up. I don't know specifically how it will come up in Maryland, but I imagine the same will come up. Although Maryland's process is somewhat different in terms of their statute right now. They are very, very focused on state-sponsored plans. That's just the way that that's their authority right now.
Okay.
To the extent that the information can be broken out by payer mix, I think even if the UPL may only apply to a certain subset of those payers, having those different groups represented can be a useful comparison to just sort of get a sense of how the plans that the UPL may impact, how they stack up in terms of formulary decisions and things like that for the drug that's under review relative to these other payers in the system.
Okay, thanks. That's very helpful. I think it does seem like it'll be more important as we get further and have a more narrowed down list of drugs. But yeah, so I guess we'll keep that in consideration.
Doug, there was something you said that I need to ask. Michael, I believe. You're on the spot again. No, I just,
Michael, who?
yeah. This one.
Sure, yeah.
The lawyer, because it's been a while since I've read the statute, but you said something about us regulating the plans. We're not regulating the plans under this. So I just wanted to clarify that, right? I mean, that it's not like we're going through the insurances side of things to regulate stuff.
Yeah, so this board isn't regulating the plans, but it is, I guess, the upper payment limits set by the board will apply to certain payers. And those, yes, so those. would
Yeah.
be-
And that's what I meant by plan regulation, is if the upper payment limit applies to some plan, and I think, like, you know, it applies to all the latest I've heard is all the plans which are regulated by the OIC, which is the fully funded plans. And then I'm still not sure about if we have any Medicare authority, but so yeah, that was my understanding right now.
Yeah, and so Doug, that's a great question. So the statute that regulates this is 7405-0506, which says that it applies to claims for drugs by a health carrier, which is, you know, defined in 4843 RCW, and then health plan offered under Chapter 4105, which are the ones offered under Healthcare Authority for public and school employees. And then it does say that employer-sponsored self-funded plans may elect to subject to upper payment limits. So they could choose on their own. So if you think about like a Microsoft, a Boeing, Weyerhaeuser, one of those that has an employer-sponsored, you know, self-funded plan in the state, they are allowed to be subject to it if they choose.
Okay, thanks. That's helpful. I do, and I have difficulty when we talk about this, separating the criteria, the and criteria from the or criteria. And so I think it'd be very helpful if we could have that in writing as a summary that we have in front of us all the time, because it could be tough to keep it all straight. And I do think, and I'll add that I don't know if that's if we think that we need the lawyer's interpretation on that, then that would obviously be preferable. So thanks.
I was gonna say, there's another question. Looks
Ronnie,
like
The public, usually those would be reserved for public
the
comment.
public comment, okay, so
Yeah.
we'll hold off on that one.
I have a comment and question. So, Ben and Matt, thanks for the comprehensive review of that. I concur with everything you said. Have you done work on how we set those upper limits yet? I know it's, you know, months and years down the road, but just how would that work? I don't know if you've done some work on that.
Yeah, we do have a sort of sister white paper about upper payment limits and some considerations for upper payment limits. Obviously, there's less, you know, sort of experience with this because, you know, Colorado is the first state to have said that they're going to set an upper payment limit, and they're still in the process, now. But we do sort of use this sort of same general framework of sort of how can you sort of think about the reasons drugs were unaffordable in the first place around therapeutic alternatives. You can think about sort of reference pricing to sort of other drugs in the same, you know, same therapeutic, you know, all therapeutic alternatives of the drug. You can think about cost effectiveness analysis to the extent that your statute allows it. In many cases, cost effectiveness uses quality of life years as an outcome, and some states, you know, are not allowed to think about that type of literature. But, you know, some countries like Germany do this type of comparative and cost effectiveness work without quality, so it's not that you have to consider those. Then you can think about sort of like what are the out-of-pocket costs, and are those informed at all based on the sort of the structure of the rebates? So, you know, in drugs where there's a high price and high rebates, setting an out-of-payment limit could be an opportunity to sort of bring down the cost that benchmark upon which out-of-pocket costs are charged. So if patients are paying 20% or 25% or, you know, 30% of the drug's cost, if the upper payment limit's a lot lower, then that might lower out-of-pocket costs. And then finally, obviously, the budget impact is sort of thinking about sort of like, based on the price, sort of how is this going to be accessible to, how's it going to be affordable to patients? How's it going to affect premiums? how's it going to affect, whether plans restrict access even once it's on the formulary, right? So it's all sort of interconnected. So anyway, we do have a white paper that sort of walks through, in more detail some of those considerations, but it follows a very similar, framework to this one, but with maybe some more details about, processes that are done here in the US and internationally to do that type of work. But with the, exception being, nobody set an upper payment limit yet. And so, so I think it's very important to think about what are the consequences of the payment limit, how it's implemented, who it applies to, and, all of that's going to determine sort of, how you go about doing that process.
Yeah, I think just having that information helps us to do the work right now. I mean, it's like working your way backward a little bit.
And Matt can make sure Michael or Simon can share with you all the link to both of those white papers, so you can sort of review them to learn more about what we say there.
Great, thank you.
You have a comment?
Any-
Oh, no, I just. Sorry.
Yeah, sidebar. Any other questions? Anything else, Mike, anything?
And so one thing I just want to kind of point out is these are all going to be important decisions that we need to make, right? Because there's a lot of ways that we can tackle this. And so Portal's outlining some of the things that we can consider. And so I think these are going to be some of our key conversations as we're looking through. And Kelly will talk a little bit about more of this later here. But I think these are all going to be things of, how do we want to define, excess cost to patients, and what measures are we going to want to use? And so I think these are all important pieces of options that we have. And so we need, as a board, we then need to figure out, which path do we want to take, which metrics do we want to use. So I think this will be good. And even to Doug's point of, defining certain stuff, right? We've defined a drug in our WAC. We've also talked about our policies a little bit about defining how we want to do things. So I think really making sure we understand and clarify those definitions if we have questions around them will be important.
Mike, are the WACs similar from Washington to Colorado and some of the other states for this book?
Similar, yes. There are definitely differences, but we've looked at other states' WAC to help inform our own. But then, of course, our own legislation requires different things, and then we've gone through our own internal review process to help define or clarify certain things that we need to. So yes, we have similar pieces within our administrative codes across the state, but they are very substantially different in other aspects as well. So
Yeah, I asked the question because we don't need to reinvent this. If Portal is helping us, the criteria, and can probably help us reconcile what we need to know. Because if we're using the criteria and it's recommended by Portal and it's 90% is in agreement, the list is already there for us to look at, and everything else Colorado has done would be similar. So it's hard for me to see how we can deviate much from the other states, just to save some work.
I was gonna say, I think also that paper, if you've had a chance to read that paper, the conducting drug affordability review, sounds really helpful. And I think the background on that paper will be really helpful in terms of guidance for us, in terms of how we think about this.
Yeah, I completely agree. Not reinventing the wheel and using these great resources that we have in the white papers. But I guess one thing I would say is I think there are some important differences in the laws, right? So, like for instance, I know that our wholesale cost whatever criteria is $60,000. I think Colorado's was $30,000. So we're gonna get a different list of drugs to begin with. And then another thing is, and again, back to my question about the list of payers for whom the upper payment limit applies, I don't know, but I think that varies across state. And so, and that could lead to big differences in how I make a decision.
I'll make just two other points here on that note, and I think we sort of talked about this last time as well, but just as a reminder, you know, there are many drugs that are going to be eligible, even, you know, there's strict thresholds and your staff are helping you sort out which drugs are going to meet those statutory thresholds, but there's still going to be a long list, particularly at the beginning of this process, right? There's many drugs to choose from. So you do have to make some sort of strategic decisions about sort of where to start. You know, and second is just sort of one question around sort of like, how do you start sort of broad or do you start sort of narrow within particular conditions? So, and I think there's reasons to do both. But for example, if you were to, you know, given that you sort of are going to look at therapeutic alternatives, I think that's, you know, specifically outlined in your statute. If you select a bunch of drugs that are therapeutic alternatives to one another that treat the same condition, then you can sort of do a kind of comprehensive analysis that affects multiple drugs. Whereas if you choose, you know, drugs from, you know, diabetes and inflammatory conditions and, you know, multiple sclerosis and, you know, many other different diseases, then you have to sort of think about everything. And you also have to think that, you know, sort of ultimately, if you go down the process of determining on affordability and setting upper payment limits, you know, how does it work to set the upper payment limit for one drug as opposed to many drugs together? And so there is like maybe a sort of a strategic decision around sort of priorities there, because again, you're gonna have lots of drugs that are eligible to proceed, and you know you have some factors that you have to think about when you decide whether to proceed. But within those, there's still going to be some still I think a lot of latitude to make some of those decisions.
Anything else? All right, well, we'll go ahead on to our next item, but again, want to thank you. This was a great presentation, really appreciate it. And I'm sure we'll see you again.
Sounds good. Thanks for having us. It's good to see everybody.
Thanks, guys. Bye.
So next agenda item, we'll turn it over to Simon, Mike, and Kelly.
Great.
Look at the eligible drug list methodology policy.
Yeah, so I can just talk about this a little bit. So we will be going, oh, Doug, do you have questions?
Sorry to interrupt, but I just wanted, before you start on this, can you just clarify the difference between the next two items on the agenda? They look so similar.
Let me look at it quick.
Yeah.
So one of them is going through the policies, and we're not going to go through them in detail. Those were sent out earlier and they're posted on the website. But just kind of introducing the concept behind why we're drafting a policy of how we're going about putting together the drug list. And the next one is a presentation that gets into more detail of, okay, what are the actual buckets that the drugs are being classified into, how many drugs fall into those buckets, what's an example of how that's being calculated. So one is setting the scene, the other one is a little bit more detail.
Okay, great, thank you.
Yeah, thank you. That's perfect, Simon.
Implementation.
Yeah, exactly. So the first one here is just the policy, which is guiding how we're doing this. So we sent this out to the board here previously. We've been discussing it over the last couple meetings of how we would be creating this drug list according to the various buckets and calculations that we're required to consider with the legislation. And in the next one, we'll go into it because at the end of the meeting last time, the board was asking, can we see more kind of examples of it, how all of this works and how the calculations play out. So we'll talk a little bit more about that in kind of a draft of what drugs will be on or how many drugs we have in each category using this policy. The one thing I'll note, so we gave the policy out for the board to review previously. We did add just at the very end on page number 4, just a note on the methodology on why, for example, we were using the high dose and duration of therapy. So I guess did you have a chance to look over that? Any questions on that? I can read through it if you want really quick. It's not long.
Questions? Doug,
I'll just note that I like the note. It answered my question about that exact topic. So great note.
Okay. Perfect. And I guess Ryan, did you have any other thoughts, comments on that?
Nope, but apologies that the link in there did not come out, so we can always provide that as a separate URL in case that they're interested.
yeah.
Okay.
Oh, I see.
I didn't realize it didn't come out.
Okay. So yeah, so that was just one of the things we wanted to explain the why we're doing what we're doing here on this. So that way we were clear and covering our bases and how we're moving forward. So any other questions on the policy?
I had some specific questions on specific items in it. I don't know if it'd be better to provide that in writing as questions for the each item, or if we're going to go through that document.
Oh, we can. We're here right now, so if you have questions, let's chat.
Okay. And yeah, I mean, this is a public facing document, right? This is going to be describe everyone what we're doing.
Yep.
Okay. So I don't know if it's possible to share the document with everybody, or if I should do that.
There we go. I think Simon's on it.
Great. Okay. The first thing I noticed was in item 2. So like this one, identifying up a little higher there. The bold is 2, identifying prescription drugs for affordability reviews. I think this is identifying prescription drugs that are eligible for affordability reviews. Is that correct?
Yes.
I think we should say that because otherwise it seems like we're actually choosing the ones to do the affordability reviews on, or could anyway.
Okay, excellent.
My next question was in on the same page in item 1A there. So I haven't used the first data bank data before. That's a national level database of pricing information. Is that right?
Yes, that is correct.
Is there any reason that we would expect like any of the drug pricing information to vary across states? So for instance, I don't actually know if the WAC can vary across states.
So this is Brian Pistoresi. To my understanding, it would not. The WAC would be set, for any of the wholesalers in the country, and then there might be different, chargebacks or other discounts that happen between the sale between the manufacturer and the wholesaler, but the WAC should be the same across the country and not different between states.
Okay, great. That's perfect. Next item in 1C there. So this is actually Ben did a good job answering this question for me before. In 1C, I thought indication would be very important. But I agree that it makes sense to only break it down at that level when we've narrowed down the list a little further. So we need to worry about that. Okay. And let's see. Okay, on the next page. Okay, in item E. Okay, so let's see. So it says current WAC means the most recent WAC. Right, so the last sentence. NDCs with no price increase in this period will not be eligible for price increase calculations and review. Oh, no, sorry. First sentence. Most recent WAC listed for NDCs that increased in price in the calendar year. Don't we need the WAC regardless of whether or not they increased in price? Not sure if I was misunderstanding that, but it seemed like we would need to define a current WAC even for those that did not increase in price.
So Doug, I think that is captured in 1B, where it says the initial WAC. So I think that's where that's captured, and then E is specific for calculating the price changes that occurred during the year.
Okay, great, that makes sense. Yeah, I think your note, I had a question about F, but your note clarified that, so that's great. Okay. So in item J there. So when we, in the second sentence of that, talks about how biosimilars could be eligible for review, even if their reference biologic is obsolete, expired, or withdrawn. And my question about that had to do with the fact that aren't we defining our eligibility criteria for biosimilars is based on the comparison of their price with the reference product, correct?
Yes.
So in that case, how could we have a biosimilar be eligible? How could we compare their price to a reference product if the reference product is obsolete, expired, or withdrawn?
That's a great question. So going back to 1.2, it's the initial wholesale acquisition cost of that biosimilar when the biologic was out.
And so we would still, let's say that was in, do we have a time span for that? I mean, what if that was years ago that we made that comparison?
I think that's how the RCW is written, is that we just look at the initial wholesale acquisition cost.
Right, so the biosimilar could be like 7 years old, and at the time the reference biologic wasn't obsolete or withdrawn or expired yet, but then now it is, but the biosimilar is not obsolete, withdrawn, or expired.
And so that would still be eligible even if our comparison of price occurred 7 years ago.
Yeah, well, in the bill it says that the drug has to be on the market for at least 7 years.
Right, okay. Okay, well, I mean, it seems like that's going to be a rare situation anyway, so I don't know if we're actually going to capture any drugs, but I was kind of surprised by that.
Wouldn't we be able to just review that product on its own ground and not necessarily need to reference it back to whatever the brand was? I mean, could we do that? Or does biosimilars always have to refer back to the original branded product?
So this is Ryan. So the way that the RCW is written is that it does say back to the reference biological product. So the way that we did our methodology is that we looked at what ANDA or supplemental BLA was tied to the originator in the purple book. So that way we could say that this product is a biosimilar to this, approved BLA.
I guess my question would be, even compared to the reference product, and the criteria will find that the biosimilar is still high and affordable. I mean, wouldn't that stand on its own without needing to reference it back?
In the case that the biologic does not meet the $60,000 threshold, because that has that dollar threshold and this is a percentage one, there are cases in which a reference biologic would not meet 1A, but the biosimilar would meet the criteria too. So there are
Still look at it.
there are some, and I think we may see some in the future.
Yeah. I think that helps answers that question. Like, does it have to reference back if it's too far away, but on its own standing, it's still extremely high and unaffordable, and we have to have a mechanism to look at that as well.
I see. Yeah, that makes sense. I was not thinking of how it could meet eligibility on item 1 alone. So, okay, that's helpful. Okay, so if we scroll down into, I guess this is on page 3 now. Yeah, so that first item I there at the top, what was the rationale for choosing the highest age range? So it says multiple age ranges, dosing types, disease durations. We just chose the highest. We think that's maybe going to be the most expensive. What's the rationale there?
So this is Ryan. When we were looking at the different age ranges that were available, there were a lot of different ones in the pediatric and adolescents, and most of the highest ones were either 18 to 110 or some other age range that captured an adult population. It was also the most wide, and we felt that that one was the one that was the most inclusive of patients that would be using the drug. So even though it says, you know, here's the highest age range, when you have the data in front of you, you see that it does encompass pretty much everyone 18 to 65 or 18 to 110.
I see. Yeah. So I definitely agree with that rationale. We want the most commonly used type, sort of course of treatment as part of our definition. So I guess like my question would be, why wouldn't we say that, like sort of what you just said, as the most commonly used course of treatment among adults, or the most commonly used course of treatment, rather than define it by the age range?
So this is right. I think the way that we set up the kind of script, because one specific NDC is going to have up to like 6 or 7 or 8 different kind of age ranges depending on what the drug is, like an antibiotic. So we just kind of set the script to choose the adult one, which was the highest one.
Okay. I mean, I guess I agree. It reaches the same endpoint. It was just kind of the rationale to me wasn't as clear with seeing it written as defined by the age range. But yeah, I don't think it's
being written more in terms of like, for a data person pulling the data out of a program. So that way it's from a technical standpoint, that's how we can understand it.
Okay, that sounds good. And then in item 3 there, let me just try and remember what I was thinking about here. The high dose per, so let's see. So if they have dosing data for both acute and chronic, the high dose per day for chronic or both acute and chronic will be utilized for the course of treatment. So I guess I don't understand that language there. You're saying you're gonna use it's the highest of either chronic or acute and chronic? Is that right? I don't understand how we're defining that course of treatment, the dose.
So this is Ryan. So for some of the drugs, they could be used for an acute situation, or they could be used, for a chronic. So what we decided is that we would look at the, chronic phase for this, assuming that these people who may be using this prescription drug may be using it for that chronic condition. And that's the way that we would calculate a course of treatment cost.
This is Kelly. So in the FDB for disease durations, it has the categories acute, chronic, and both acute and chronic. So I was trying to reflect that here, but yeah, it's kind of confusing because of the way that wording is for the categorizations.
So basically, you're just going to choose the highest of any of it. If it can be used for both, we're going to use, as we define high dose, we're going to choose the highest that it can be for any of the options. Is that right?
Yeah, and
right.
I think. Oh, go ahead, Kelly.
Oh, this is Kelly. I was just going to add that there actually is a category called both acute and chronic. So what I was trying to say here is we're going, if the drug has like chronic or the category of both acute and chronic for the dose, then we're going to use those.
And Doug, I think an example that we looked at was, for HIV medication. So PEP, post-exposure prophylaxis, versus PrEP. So PEP, is going to be a shorter duration, and that was labeled kind of under the acute use, whereas, PrEP or, HIV treatment were chronic. And so we would look at that as kind of the way to differentiate between acute and chronic use within this data set.
Okay. Great. Thank you. That makes more sense now. And I think, yeah, all my other comments and questions were related to that indication level thing, which we've already discussed. So that is it for me. Thank you very much for providing those details.
Any other questions?
I just have. This is more just in general for when we're developing all of our policies. I think that we have confusion. I have confusion when we say WAC because it's wholesale acquisition versus
Washington
Washington
Administrative
Administrative
Code.
Code. So I know you have it specifically in your, you spell it out on the first time it's used, but I think maybe in the policies, we're gonna have to like have something just generically to spell it out.
Or WAC price.
Yeah, WAC price, I think.
Or something
Yeah,
after,
just
yeah.
Yeah, just so that, because it was when he was asked a question that I was like, wait a minute.
Or we could use list price, because I think in statute, they use wholesale acquisition costs throughout, and so I
Yes.
think we can use a.
I remember we had some difficulties in those discussions.
We did, yes.
We have to be careful about it. There's a lot of prices.
Yeah.
Like acquisition.
PDAB.
Yeah,
That,
yeah, so it's just, when, as we go through forward with policies, trying to make sure we're clear on what we're talking about.
We can do that.
Right. How about a 5-minute break?
Do the
You wanna
votes?
vote first?
Yeah,
Yep.
Okay.
No votes.
Well,
We
we
don't
was-
have to.
I thought we had to vote on this.
No.
that was next time.
Oh, it's next time.
Yeah,
Oh,
we'll
all
vote,
right,
we'll
okay.
vote in July.
All right, fine.
All right, so 5-minute break. Get our legs.
Here, I didn't read it right.
Two reasons.
Came across a white kid on written for. In the national, state health policy institute sponsoring the seminar we're going to.
Ready to go? All right, and here I'm fooling around. All right, well, let's go ahead and get started. And Kelly.
Okay, can everyone see my screen okay?
Yes.
Yep.
Okay, great.
Good.
All right, so today I'm going to, as Mike mentioned, go over some examples that apply our methodology for identifying prescription drugs that are eligible for affordability review. And then I'll also show the preliminary number of NDCs that we have identified as eligible for review for each section of the bill. Okay, so in this presentation, I'll briefly go over the bill and the various ways a drug can be eligible for review. We will go over some examples for the calculations for each section of the bill, and I'll show results, and then we will have some time for questions and discussion, and then I'll share the next steps we are working towards. So this chart illustrates where we are in the affordability review process. So right now we are at the really broad end where we have identified eligible prescription drugs for review. And then as we move along in the process, the board will eventually narrow down and choose which drugs the board wants to perform affordability review on. So briefly, this is part of the bill that lists the various criteria that make it prescription drug eligible for affordability review. And I know we have been through the methodology in great detail for each section, so this presentation will focus more on examples showing how we apply that methodology. All right, so I'm just going to go in the order of the bill. So first up, we have brand name drugs or biologic products that have a WAC of $60,000 or more per course of treatment lasting less than 1 year. So to calculate this, and you have seen this before, but just a refresher before we jump into examples, we're using the first data bank dosing modules, which contain drug dosing data by age category. And these are the terms that I'll be using throughout this section. So the term high dose refers to the dose we'll be using for our course of treatment calculations, and it's the high dose per day of a drug. So for example, maybe most people are prescribed 5 milligrams of a drug per day, but the drug can be prescribed for a high of 10 milligrams a day. So the high dose in this case would be 10 milligrams a day. And then the high duration of therapy means the high end in days of the recommended amount of time that a drug should be taken. So for example, some people might take an antibiotic for 10 days, but it can also be for certain conditions be taken for 21 days. So in this example, the high duration of therapy for this drug would be 21 days. Also, in some of the examples, you might see that the high duration of therapy is 0. And this means that the dose for that drug is a chronic dose. So we interpret that as the dose has to be taken daily. So for 365 days a year. Disease duration refers to the duration of the disease or health-related condition associated with that NDC. So as Doug asked before, this can be acute, chronic, or both acute and chronic. So for example, antibiotics may be associated with an acute disease duration. Antiretrovirals may be associated with a chronic disease duration like HIV, and then something for treating asthma could be associated with both acute and chronic disease durations. And then finally, maintenance and single dose refer to the types of drug doses. So maintenance dose is the amount of dose you would need to take to achieve a steady concentration of the drug in the system. And a single dose is the amount of one-time dose you will take.
Kelly, Doug has his hand up.
Go ahead.
Thanks. Yeah, just a quick question. Can you just tell us what years of the FDB data you're using?
So for this course of treatment, we're just pulling the most recent price that the drug has on file, but in other sections, we'll be using like a certain time period, which I'll explain.
Okay, so but I mean, in your overarching data set, like how far back does the data go? I mean, or actually what and how recent and how far back does it go?
You mean like the FDB in general, or
Yeah.
what? So they only keep, I forgot how many price histories, but they, I guess in the, oops, sorry, I muted myself, but I guess in the interest of space, they only keep like a certain amount of price history. So if the drug is like 20 years old and it had a bunch of price changes, the FDB might not have all the prices for that drug. So I'll need to look into like exactly how many price histories they keep, but actually for price we're using Metaspan, and they also keep a limited amount of price history, but it's more than what the FDB keeps.
Okay, so I guess, so I can go back a long way, but then how about, and then how recent, what's like the, like if there was a price change yesterday, we wouldn't see it, but maybe we'd see it if there was one 3 months ago, what's the?
Yeah, so I'm not sure about like the refresh process for us, but for our drug review, we're looking at prices as of January 1st, 2023. And I'm guessing that next year we'll look at prices as of January 1st, 2024.
Okay, so that's like our data freeze is on January 1st of last year. And we'll do that every year.
Yeah.
Okay, thanks.
All right, and yeah, feel free to interrupt me if you need any clarifications or have questions. And then lastly, billing unit is the form of the drug, so it can be each millimeters or grams. Okay, so a quick summary of the methodology we're using to calculate the course of treatment, which you have seen in great detail in the past. So first we deduplicated the data so that each NDC only has one dosing data record for calculation purposes, because an NDC can have multiple dosing data for different age groups. After that, we multiplied the NDC's high dose by the high duration of therapy in days to get the number of NDC units used in a year. And then we multiplied that by the NDC's WAC unit price to get the cost of a course of treatment for 1 year. And the goal of deduplication is to choose 1 dose per NDC to use for the calculation for the course of treatment. And we want to obtain the highest amount of an NDC someone could take. So this includes choosing the data for the highest age range and choosing the chronic and maintenance doses. So this is the formula that we're using to calculate the cost of a course of treatment. So we want to take the high dose per day and divide that by the strength of the NDC, so we know how much of the NDC the person is taking per day. And sometimes the units of the high dose per day and the NDC strength aren't the same. So we may need to multiply the high dose per day by a conversion factor to get it into the same units as the NDC strength. So we can actually do the division. And then next we multiply that by the high duration of therapy in days that the NDC should be taken. And then we multiply that by the WAC unit price to get the cost of a course of treatment for a year. Okay, so let's jump into our example for calculating this. So for this example, we're going to look at data for Renvela, which is a drug that lowers the amount of phosphorus in the blood of patients receiving kidney dialysis. So after the deduplication algorithm, we have that the high dose for Renvela showed here is for patients aged 65 to 110, and that dose is 14,000 milligrams per day. And so in the previous board meeting, I talked about needing to do unit conversions for some of the NDCs in order to calculate the course of treatment costs. So I purposely chose this example where a unit conversion is involved. So here, if you look at the high dose unit description column, which is the second column from the left, and the NDC strength unit of measure column, which is the last column from the left, the units are different. So the high dose unit is in milligrams, while the NDC strength unit is in grams. So you can't divide these unless they're in the same units. So in order to calculate how much of an NDC is used per day, we need to convert the high dose from milligrams to grams so the units match. So that translates to multiplying the high dose per day, which is 14,000, by 0.001, because 1 milligram is 0.001 grams. And then after we have converted the high dose per day to grams, and they're in the same units, we can divide that by the NDC strength. So after we do that, we can multiply that by 365 because it's a chronic medication dose, and then multiply that by the WAC unit price of $17.85. And that gives us the cost of $114,016.88 for a course of treatment. And so once again, after plugging the numbers into our formula, we have that Renvela cost $114,016.88 for a course of treatment for a year. And this exceeds the threshold of 60,000 for review. All right, I'll stop for a second and see if there's any questions on the example. All right, hearing none, so I'm going to move on, but feel free to stop me if you want to come back to this. Okay, so moving on to the brand and biologics with a 15% or more increase over a 12-month period, or a 50% or more increase over a 3-year period. All right, so I think at the last few meetings, we talked about this. I didn't emphasize that we're only looking at NDCs for this section with an increase in the period between January 1st, 2022 and January 1st, 2023. So that, like it mentioned in the policy, if the NDC did not increase in this time period, then they won't be eligible for review for this section. So the term current WAC that I'll be using in this section refers to the NDC's WAC unit price from the most recent price increase between January 1st, 2022 and January 1st, 2023. And 1-year WAC will refer to the NDC's earliest price unit WAC unit price in the immediately preceding 12-month period from the date that the current WAC was set. So if the NDC had no other price increases in that period, then we'll use the NDC's price at the beginning of that period. So for example, this means if we're using the NDC's most recent increase that happened, say, in December 2022, and they had 3 other increases between December 2022 and December 2021, we're going to use the earliest increase in that period for the 1-year WAC. And if the NDC had no increases other than their most recent increase that period, then we'll use whatever their WAC was as of December 2021 as the 1-year WAC. I don't know if that made sense, but the example that I'm going to go through is kind of contains this scenario, so hopefully that'll make it more clear. All right, so this is the example for calculating the 1-year price increase. So we'll subtract the 1-year WAC from the current WAC and then divide by the 1-year WAC. Okay, so this is the example for this calculation. So this data is for Lovaza, which is a drug used along with a low-fat and low-cholesterol diet to lower very high triglyceride or fat levels in adults. So this drug had a price increase in December 2022, which makes it eligible for review. It did not have a price increase in the immediately preceding 12-month period, which would have been between December 2nd, 2021 and December 2nd, 2022. So we are using its price as of the beginning of the 12-month period, which would be whatever its price was as of December 2nd, 2021. Happened to be set on October 1st, 2021. So plugging the numbers into our formula, the current WAC is $6.12. The 1-year WAC is $3.30. So that means there was a 85.45% increase in the past 12 months. All right, so then that means that Lovaza exceeds the threshold of a 15% increase in a 12-month period and is eligible for review. Okay, so the methodology for calculating the 3-year increase is really similar to the 1-year, except we're looking at the immediately preceding 3 years instead of 12 months from the date that the current WAC was set. So the formula is very similar, except now we're using the price from the immediately preceding 3-year period instead of 12 months. So we're going to go back and look again at Lovaza. But this time we're looking at what the increase was in the immediately preceding 3 years of its current WAC. So that 3-year WAC in this case would be either the earliest price increase between December 2nd, 2019 and December 2nd, 2022, or if there was no other increase in that time period, the price of Lovaza as of December 2nd, 2019. And the 3-year price for this drug happens to be the price set on May 21st, 2021. So even though this drug has been on the market for 7 years, this price from May 2021 is the oldest price in the database. So I mentioned before that one of the limitations of our drug pricing databases is that it only keeps a certain amount of price histories. So for some drugs like this one that has been on the market for a while, it may have had a lot of price changes since then. So we won't have some of the older prices. So actually here we might be underestimating the increase, because if we assume that drug prices increase over time, if we looked at an even older price for this drug, it might have been even lower than the one set in May 2021, and therefore the increase would have been bigger. And so, yeah, so plugging in the numbers into our formula with what we have, the current WAC being $6.12 and the 3-year WAC being $2.87, we get that Lovaza increased by 113.24% in the immediately preceding 3 years. And that means that Lovaza increased by roughly 86% in a 1-year period, which is greater than an increase of 15%. And it also increased by 113.24% in a 3-year period. So this is an example of a drug that exceeds both the 1-year and 3-year thresholds for review. Any questions about this section? All right. All right, so moving on to an example of a biosimilar with an initial WAC not at least 15% lower than the reference biological product. And so we'll calculate the increase using the price of the biosimilar's earliest listed WAC unit price and comparing it to the price of its reference biologic at the time of the biosimilar's earliest listed WAC unit price. And so the formula to calculate the increase will be the initial biosimilar WAC minus the reference biologic WAC divided by the reference biologic WAC. And so the data we are seeing here is for Truxima, and it's a biosimilar to Ritazan. I'm just winging it with the pronunciations. And it's a prescription infusion for certain forms of cancer, rheumatoid arthritis, and blood vessel disorders. So the initial WAC for Truxima was $84.56, and this was set on November 9th, 2019. And its reference biologic, Ritazan's price as of that date was $93.95, which was set on July 1st, 2018. And so I think that kind of speaks to like what Doug brought up about how like some of the reference biologics may be expired or withdrawn or obsolete. So we're looking at data from like 2018 and 19 here. So it's possible that between then and now, maybe, well, I know Ritazan's probably still on the market, but like, for example, Ritazan could have been expired, withdrawn, or obsolete by now. But its biosimilar is still current. So plugging these numbers into our formula, we get that Truxima's price was only 9.99% lower than its reference biologics price at the time it came onto the market. And so that means that it's not at least 15% lower, and this qualifies Truxima for review. All right, so finally, let's see some examples of calculating the WAC cost of a 30 supply or less and increase of 200% or more in the past 12 months for generics. Okay, so the steps to identify generics that qualify for review are pretty similar to the course of treatment steps. So we'll implement the same deduplication process. So we only have 1 dose per NDC for our calculations. Then we'll calculate the price increase of the generics over the past 12 months. And then we'll only look at the generics that have a 200% or more increase. And then out of those, we'll calculate the number of NDC units used for a 30-day supply. And then we'll multiply that by the WAC to get the cost of a 30-day supply. And we chose to do it in this order so we could kind of like whittle down the NDCs as we go, but it doesn't have to be this order because the results would be the same because the NDCs have to meet both criteria to qualify for review. And then, yeah, it's just more helpful for us because we might need to do some manual review of the unit conversion in case some of the unit conversions aren't as straightforward. And so this is the same deduplication algorithm for the course of treatment. So I'll just gloss over this slide. And so to calculate the increase of 200% or more in the past 12 months, we're using the same formula as calculating the 1-year increase and the 3-year increase. So this is like the same slide and same formula. All right, so once we get like the NDCs with the 200% or more increase in the past 12 months, we move on to calculating the cost of a 30-day supply or less. So to calculate that, we're going to be looking at the high duration of therapy in days. So if the high duration of therapy in days is greater than or equal to 30 days, we're going to multiply the NDC units used per day by 30 days. And then if the high duration of therapy is less than 30 days, we'll use the exact number of days that it is. So this way we're accounting for the cost of a 30-day supply for NDCs that may be taken daily for chronic conditions because the high dose will be multiplied by 30 to reflect that. And also account for NDCs that aren't taken chronically, like antibiotics, because the high dose will be multiplied by whatever amount of days, say like 10 that you're supposed to take it for. And so This formula for calculating the cost of a generic whose high duration of therapy in days is greater than or equal to 30 is really similar to the formula for calculating the course of treatment, except we're cutting off the high duration of therapy at 30. And the formula for calculating the cost of a course of treatment when the high duration of therapy in days is less than 30 is exactly the same as the course of treatment formula you saw in the previous section. Okay, so the example I'm using here is data for primidone, which is an anticonvulsant used to treat seizures. So the current WAC was set on March 22nd, 2022, and the 1-year WAC was set on September 1st, 2010. So this is an example of a drug that didn't have an increase for a pretty long time. And so the price for primidone was 8 cents as of 1 year prior to March 22nd, 2022, which is March 22nd, 2021, because the price hadn't changed since 2010. And so plugging in the numbers into our formula, we have that primidone increased by 200% in the preceding 12 months. So since primidone meets one of the thresholds for review, which is that it increased by 200% or more, we move on to calculating how much it costs for 30-day supply or less. So after we apply the deduplication algorithm, we're using the maintenance dose for ages 18 to 110 for this calculation. And the high duration of therapy in days is 0, which means that this information is for a chronic dose or 365 days. So this means we'll use the formula where the high duration of therapy is greater than or equal to 30 days, and we'll cut off the high duration of therapy at 30. So in this case, the units of the high dose and NDC strength are the same, so no unit conversions are needed. So after plugging in the numbers, we get that the cost of a 30-day supply is $288. And so this means that primidone meets both criteria for review. So it increased by exactly 200% over a 12-month period, which meets the 200% or more increase. And it also costs more than $100 for a 30-day supply or less. So this is the end of the example section. So I don't know if anyone has any questions, or I can move on. All right.
Questions?
Oh.
Doesn't look like it.
Okay, sounds good. Well, there'll be a questions section at the end if anybody thinks of anything. All right, so finally, after getting everyone deeply acquainted with how we applied our methodology for each section of the bill, this is what we've all been waiting for, which is the number of NDCs that are eligible for review for each section of the bill. So I'm just gonna let this sink in. And there are 455 distinct NDCs that are eligible for review. And I'll talk more in our next steps about how these numbers may change. Primarily having to do with us looking at other eligible NDCs of the same labeler as the currently eligible NDCs.
Can I just ask, do you happen to know what the total number of NDCs that you assessed was?
No, but I can look that up, and yeah, I can mention that next time.
It's gonna be like tens of thousands, right?
Oh yeah,
Lots.
definitely.
Okay, great. Yeah, this is, I mean, really great presentation, and looks like, I think the methodology looks really good. So thanks.
Thanks. All right, so I guess I'll move on from this table if everyone is done looking at it. Okay, so other than the next step slide coming up, this is pretty much the end of the presentation. And I know that was a lot of material to absorb. So if you have any further questions or things you want to discuss or for me to go over again, we can talk about that now. All right, well, if you think of any, oh,
Yep.
Go ahead.
Yeah, I mean, going through this, like one of the things that really sticks in my mind is just, all right, one of my biggest questions I have is how important is this high dose, high duration qualifier that we're applying when we select these drugs? I think that we'll definitely want to know that for when we're doing the prioritization for affordability review, and then even possibly at the affordability review stage. You know, it's the type of, I wonder about this type of situation where, like, 0.01% of users have this high dose, high duration. And so then they're qualifying as, eligible for affordability review. But we're missing like the 99.9% of users who have a much lower dose, much lower duration, and therefore it's not very expensive for. And so I just want to, I guess if there's any way that, I don't know if you think it would be helpful now, Kelly, as you're going through this process of applying the eligibility criteria, to sort of, I don't know, including your data set or flag things that you think would be helpful for assessing that going forward, assessing how sensitive this step is to that high dose, high duration qualifier. Does that make sense?
Yeah, and I think Ryan and Donna can speak more to this as well, but I know in the affordability review process, we're going to look at utilization. So that'll kind of tell us like how many people are using this dose, and maybe we'll look at how many people are using other doses.
Yeah, and then also, I mean, like, we might also be missing, let's say that the 99.9% of people who are using at a lower dose, that also would qualify for affordability review. We might then see that the utilization at the high dose, high duration is very low, and potentially miss a large number of people who are using it at a lower dose, lower duration, but still quite unaffordably. Does that make sense?
Yeah, that makes sense.
Yeah.
Yeah.
I was just gonna say, yeah, this is Ryan. So I think, what we're looking at is in the statute, it just says, here are the thresholds for you to determine what is going to be part of the affordability review. And then during that affordability review, you're going to get into a lot of that information about, are there people below that high dose that still have affordability issues, right? Because as you saw from the portal presentation today, you're going to be looking at some of that state budget impact, or the patient out-of-pocket cost, or the therapeutic alternatives, right? And so you'll start to get a better sense of what is the scope of the affordability challenge in that population, really more at that time. But because at this time we're looking at, what qualifies, or what could meet these thresholds, we aren't able to get into that level of detail yet.
Okay, sounds good.
And I think this is how I think we're gonna look at all of it, right? The high dose, the maintenance, and so it's just, whatever makes the most sense that would work for that NDC. I think high duration, I think about gene therapy, right? It's a one-time use, it's just a one episode, and it can be extremely costly, right? And so I think it's a method to capture those. It's the one-time cure. I think about the Hep C right back in 2013 when it came out. It's a 3-month therapy, but it was $100,000. And so just capturing those.
So I just have a question that I'm trying, my pea brain trying to correlate. So on number 1, with the numbers that are there, so that, and then 1A versus 1B, are there some of the Bs in, are they separate, or it's either or? I'm just trying, it's because I know the language says or, so that's why I was trying to.
So are there duplicate drugs in
Right,
those two categories?
Like, in other words, drug A, brand drug A could be over 60,000 and have had a 50% increase. So would it, have we done any identification that way? So like the drug would show up in both ones. That's my question, I guess.
So this is Ryan, and I think when I was looking at this, I did them independently, so I did not verify whether there was a crossover for the brands. But that would be worth looking at, right? Because I remember they were two, separate files.
Right.
And I didn't actually look at, okay, well, this list is this drugs and this list is these drugs. But that's something we can do. Okay.
Yeah, that's a great question. So the way we pull this data, we just went like one section at a time. We didn't say like, oh, if this drug is in this section, then it's excluded from that section or anything like that. So yeah, there's definitely overlapping, like drugs that overlap the sections.
But when we start wanting to choose drugs to review, we might want to see if the drug shows up in more than
Right.
two votes.
That's a good point.
Trifecta.
All right, well, if there's nothing else, then I'll move on to the next step slide. And feel free to, yeah, reach out to me if you have more questions. And so, as I mentioned before, we not only want to look at eligible NDCs that we identified in the table I showed, but if we select an NDC for review, we would want to look at the other NDCs that are of the same labeler, brand name, active ingredient, and formulation as that eligible NDC, just to see, So as we move into the affordability review phase, we're going to identify these other NDCs related to the currently eligible NDCs. And then in the next presentation, in this meeting, I'll give a brief overview of what's coming next, which is developing a methodology for selecting the eligible drugs for affordability review. And that's the end of this presentation.
Any more questions?
Just a quick one. In that first bullet of next steps, is that suggesting that we could add other NDCs to our list of eligible drugs aside from the ones that you identified with your process?
So Doug, yes. So when we were doing our eligibility review, we do see that certain drugs will have various kind of, subproducts in them. So I think a good example is Humira, where Humira has like a Crohn's disease, starter kit. And so as we are thinking about doing the affordability review, we've identified that, Humira NDCs, meet that threshold. And as we're looking at the utilization and the cost across all of the drug of Humira, that we would identify those NDCs and make sure that they were part of that. Because we don't necessarily say, that we would just be looking at one, specific NDC of Humira only. We would be looking at kind of all of the NDCs of Humira. We're doing that utilization review and giving you a full broader scope of what the drug's impact is on patients' affordability.
Okay, great. Well, that's very helpful. I'm glad we're doing that. That wasn't clear to me until just now that we could. I thought we could only look at NDCs that fell into one of those three categories.
Right. So I think, like, for an example, someone would start off on that Crohn's disease starter kit for their first fill and then move into the maintenance dose and then, be at the 40 or the 80 or kind of whatever they need to control their disease. So we would potentially miss those people using that Crohn's disease starter kit because it's a one-time, it doesn't meet that $60,000 because it's just used once. But we would want to include that because we know that a patient would potentially start on that NDC and then move to a different NDC, but for the same drug.
Okay, sounds good.
Or different formulation.
Or different formulation.
Yeah.
Exactly. Yep. The CF is a good example.
All right. So we're ready to move on. To Kelly, your last presentation.
Oh, sorry, I was muted. Yeah, sounds good. Let me just reshare my. Okay, so we wanted to give the board a brief preview of the next steps of the affordability review process. And so some of this material was discussed in detail by Portal earlier today, which is great because they're the subject matters in these areas. So hopefully some of this will be familiar and you'll hopefully already maybe have some ideas about how you want to approach this process. So I'll talk about what the bill says about selecting drugs for affordability reviews. I'll go over at a high level what the data measures the bill says that we have to consider when selecting drugs for affordability review, as well as some additional data measures that the board could consider. I'll bring up some discussion points and things to think about as we move forward with this process. And I anticipate we might spend a bit of time on this section, and then I'll wrap it up with what the next steps are, and then we can have some additional time for questions and discussion if needed. All right, so this is the part of the process towards affordability review that this presentation will cover. So the last presentation covered the drugs that were eligible for affordability review, and this presentation will talk about the process of selecting drugs out of those lists to conduct affordability reviews on. All right, so I'm going to start off with establishing what the bill says about selecting drugs for affordability review. So the bill says that when deciding whether to conduct a review, the board needs to consider the following three things, which are the class of the prescription drug and whether it has any other therapeutic equivalents currently on the market. The board needs to consider input from relevant advisory groups, and the board needs to consider the average patient's out-of-pocket cost for the drug. So out-of-pocket costs are costs that aren't reimbursed by an insurance plan. So this could be deductibles, co-insurance, or co-payments for covered services that aren't covered. And so the bill says that these three things need to be considered, but the board can definitely consider more than that, which I'll go through in the next few slides. And also relevant advisory groups refers to RCW 70.405.20. And that says that the board needs to establish advisory groups consisting of relevant stakeholders, which includes but is not limited to patients and patient advocates for the condition treated by the drug, and one member who is a representative of the prescription drug industry. I see someone has their hand up.
Yeah, thanks. I just want to clarify the language of therapeutically equivalent. I think in Portal's presentation, they had been using therapeutic alternative, and actually, and Ben discussed how, there's, the big difference between those. And so, I guess what is this? I guess we want to be clear about what we're saying here. And so, is this the exact bill language equivalent?
Yes, so Doug, this is the exact language equivalent. It does have therapeutic equivalents in this step. It does list therapeutic alternatives later on in the RCW, but for what this is word for word from the RCW.
Okay, so is it, we're looking at the existence of therapeutic alternatives is relevant when we are doing an affordability review. But at this stage, deciding whether to conduct, it's therapeutic equivalence that matters. Is that right?
So I'll go into it in the to consider, but the board can also consider other things. So also therapeutic alternatives. So this is just like the three things that you must consider, but you can also consider like other things if you want.
Okay, thanks.
Sure. So I'm not sure if everyone knows what a therapeutic equivalent is. So I'm just going to read out the definition, which is a drug that contains the same active ingredients, dosage form, route of administration, and strength as the original drug, with the expectation that it will produce the same clinical effect and safety profile as the original drug. And then also the board can choose up to 24 drugs per year to review. So how many drugs you're interested in reviewing is something to keep in mind as well as we move through the process. Okay, so now that we established the three measures that the board must take into consideration, let's talk about other data measures the board could consider. So this is an illustration of the three measures in the bill that the board must consider, but the board can also consider other data measures that they think are important. All right, so here's a Venn diagram showing the data measures that the bill says the board must consider when choosing drugs for affordability review. And like I mentioned, there are a whole host of other data measures that the board can consider. And in fact, the bill lists a bunch of them under what must be considered when actually conducting the affordability review, but there also data measures that the board can use when selecting the drugs for affordability review as well. So I thought it'd be great to start us off with these choices. So you can see on the bottom right, I have 2 red light bulbs. So this is where we're open to your ideas and input because these 2 data measures are pretty broad. So one of them is any other information the drug manufacturer or other relevant entity chooses to provide. And the other is any other relevant factors determined by the board. So I'm just throwing this out there as something you can think about. Yeah, and solicit ideas for any additional data measures you think should be considered that's not already on here. And next meeting, we'll go into these data measures in more detail and talk about the feasibility of pulling the data for them and from the data source that we have, as well as how they would theoretically be calculated. So at the moment, we aren't committed to using all of these. Right now, these are just potential options for you to choose from, and we're happy to take your ideas on what else should be considered. So this is something we're also going to talk about more in a later discussion slide. But yeah, feel free to interrupt me if you have any ideas.
Yeah, sorry to belabor this, but I thought, so on this slide and on your prior slide, we're now using alternative and not equivalent. And I thought it said, and I thought, so slide 5 said we must consider therapeutic equivalence. And now here we're saying we must consider therapeutic alternatives. Is that?
So
Yeah, that's
Doug,
a good point.
can I jump? Sorry, Kelly, I just want to jump in here. So when we are deciding to do a review on a drug, we must look at if there's a therapeutic equivalent. Once we've decided to do an affordability review and we start conducting the affordability review, we then have to consider therapeutic alternatives.
Got it. Okay. Yeah, so I think that the previous slide number 7 is a little misleading, just because and I don't know if these slides are going to the public, but because that's, I mean, it says that we're deciding whether to conduct a review and it says or shall consider alternatives. And so, I don't know, for my reference, I think it would be helpful to just make that distinction clear going forward. But anyway, sorry to stay on this point any longer. So thanks for your explanation. Yeah.
Oh, thanks, Doug. That's a really good point. It definitely should be therapeutically equivalent because that's the bill language, and I might have gotten confused.
Yeah, this one.
Yeah. But thanks for pointing that out.
Okay.
All right, so here's a brief overview of the different data sources we have at our disposal to pull data from for the measures that we want to consider when choosing drugs for affordability review. And in the next board meeting presentation, we'll have more detail about the pros and cons of each, as well as the feasibility of calculating the various data measures that are shown in the previous slide, but I just want to introduce you to the data sources that we have. And one of the most important data sources to us is the Washington State All Payers Claim Database, or the APCD. So this data set contains eligibility, medical, dental, and pharmacy claims for about 70% of the total Washington State population. And the data is collected from public, so like Medicare, Medicaid, Public Employees Benefits Board, commercial plans, and self-funded plans that can submit data on a voluntary basis. So this is going to be a great resource for us to look at prescription drug utilization and patient out-of-pocket costs. And also, as I mentioned in the previous slide, the board can also ask drug manufacturers for data. So we have that as a potential source of information as well, but it'll probably not be as easily accessible as the other data sets shown here, since it'll probably involve a process to decide what we want and how we want it to be submitted. And we also have to, keep in contact with the manufacturers and keep on top of the whole process. And same thing with the pharmacy benefits manager data. So if we want to request data from these 2 sources, we'll need to think thoroughly about what exactly we want to request and be really detailed. The bottom 2 data sources have already been used for creating the list of eligible drugs. So these are the 2 commercial pricing databases, FDB and Metaspan. So they do contain a lot of overlapping information, which you can tell, but they do each have some data like that the other doesn't. Drug price history than FDB, and FDB has information on market entry dates for drugs, while Metaspan does not. All right, so this is the part of the presentation that I'm hoping the board will chew on until the next meeting. So as we go into the process of selecting drugs for affordability review, I think Portal also mentioned this, that you want to think also about like the big picture, about like what your goal is, and that'll also help you in choosing like what data measures you want to use. So the first 3 points listed here: what is your definition of affordable? Who should the drugs be affordable for? And what do you want the affordability review to address? I think Portal has covered this really well in their presentation and also in the white paper that they linked. So I'm not going to repeat other points again, but thinking about that may help you when it comes to choosing what data measures you want to look at and determining which data measures are more important to you than others. And I don't know if anyone else on the HCA team wants to add in anything.
I mean, I guess I would say, yeah, if the board can think about these, and yeah, when you're reading like the Portal white paper, going over the presentation where it's asking, you know, when it's like, for example, defining excess cost of patients, and it's talking about some of the ways they can do that. Really think about how you want to do that, because a lot of these decisions are going to be determined, you know, which way do you want to go in terms of how we're going to prioritize some of this data, or who we're going to be looking at, or how we're going to be defining certain things. So yeah, I think like Kelly was saying, these are some things that if you can come back to the next board meeting with some of your own direction of, okay, this is what I think I want to do, and we can talk about that, that will be good.
Thanks, Mike. Yeah, hopefully the board will have some good information to go on and have some more ideas on what direction they want to take in the next meeting. And for data considerations, I know most of us just saw the potential data measures for the first time today, but between this meeting and next, something to think about is whether there are certain data measures that you think are more important than others when selecting drugs for review. Are there any data measures we haven't mentioned yet that you would be interested in looking at? And do you have a strong interest or preference for any specific data measures? So again, I want to emphasize these are things we want to think about until the next meeting. But we don't expect you to have answers right away, but thinking about it will help us move forward with the next steps. So just a brief overview into like what we think will, what we want to happen next is we want the board to choose the data measures they want to use, and then eventually we'll do some sort of ranking exercise where the board will rank the data measures that they think are most important, and then we'll try to work out a system to assign weights to various data measures based on importance that the board ranked them as, and then we'll use those as a formula to select drugs for affordability review. But we'll go into that in the next meetings in more detail.
Yeah, and Kelly, kind of along with that, and as we're thinking about these measures too, remember that this is a funnel, right? So our first methodology is getting this drug list, right? Where we have those numbers that we showed on, here's the amount of drugs for each of these different categories. This next one is, okay, how do we want to select this down? So when we're choosing these data points, that doesn't necessarily mean we want to look at every single thing. Well, in fact, we definitely don't want to look at every single thing in this next phase. This is what are the key points that are going to help me out of this list of, you know, about 400 something drugs, right? How can I whittle this down? What are the key points that'll help whittle this down to 2 or 5 or 10 or whatever we're going to be doing? And then we can think about more of the detailed points, right? For the actual drug review, where we really go into the nitty gritty. So as you're thinking about these data and what we want to do in terms of selection, keep that in mind. This is a part of a funnel, right? So what are the key pieces that are going to help us select that number? And then of course, then the other thing is, what number do we want to select? You know, we can do up to 24 for our first year. I think that's a lot. So Colorado did 5 for another example. So also thinking about that number as well in terms of as we're starting to pick out how we want to select these and what we want to select. I think that's important. And Doug, you have your hand up.
Yep, thanks. Yeah, I love these questions. Very interesting. Looking forward to thinking about these. And also I'm very excited about the I like the ranking of different measures and the weighting. I think that's an excellent approach, and I'm excited about doing that. As I start to chew in these questions, it brings me back to the upper payment limits and for whom they apply. I think that's really important because as we, it's one thing to just kind of answer these questions in a normative sense and say, what is my overarching goal of or overarching definition of affordability and those things. But it's another thing to think practically about what can this board do in terms of setting upper payment limits and for whom that applies, and then answering these questions in the context of the actual policy mechanism that we have in front of us to make a difference with. And so I guess this is what the reason I mentioned is because I really want to get that hammered out. A detailed list of plans, within the state, yes and no, does the upper payment limit apply? And it would be great if that was, an exhaustive list of every insurer in the state. Because that way, at least for me, I know that that'll help me, think about these measures and these goals and these questions. So it'd be great if we could get that. So thanks.
Any other questions or comments?
I just have one. I'm trying to figure out how to phrase it. I guess it's something I'm just interested in, if we would look at this, or whether it comes into the duration of therapy or the amount of therapy. Like our state had, there's differences between states and, of diseases. So I'm just curious if there's at any point, because it would kind of go into the health system cost or how it affects the health system. Because we have like more MS, I just happen to know, in this state than like say New Mexico. There's the band across the northern states. So, and God knows the drugs are expensive for that. So I guess is there some way that we're going to be able to see or weigh in these measures? I'm just trying to figure out where that fits in on the measures. Or, I guess like probably we're not as obese as the southern states would be, the opposite thing. So we wouldn't be spending as much in that regard. So I guess I'm just like comparison of whether it's as big of a problem, the drugs or the affordability question for as many people in the state. I'm just trying to figure out where that we fit that in or how it fits in.
So this is right. I think we'll get into that with the all payers claims database, because the all payers claims database will let us see, kind of what percentage of our population, may be using these different MS drugs, or what may be using the different obesity drugs, assuming they meet the criteria. So I think once we get to that all payers claims database, we'll start to see that a little bit more in that detail. But at least at this phase, we're just kind of looking at, what is a theoretical Washingtonian using this drug, and would that person using this drug at this dose, face an affordability challenge? But then after that, now we're starting to get more into the details of who is using it and what populations or
How
what
it
health
affects
plan.
the system.
Exactly.
I concur with Ryan. I think we have to just look at this objectively, right? The number will tell us exactly what that is. I think when we look at the disease state, we just hear a lot from each society of claiming that this is, it's important and so forth, right? Because they're lobbying on their behalf. I think, there's always the discussion of in the Northwest, the MS rate is much higher. I actually like to see the data on it because a lot. Yeah, I used to work with a neurologist that is the top of her work, right? She's like, we don't know why, right? Could be the sun, could be lack of vitamin D, I don't know. But it's just looking at the clam data tell us a lot.
Well, yeah, I'm just thinking about public health, whether we need to bring some of our public health data into it. That was what I was trying to think about. Was like obesity, tobacco. We don't smoke as much, and that is come under, yes, when we get into the system evaluation.
Are you thinking about it that way, more to look at how you would select drugs to review?
Yeah,
Because they are more, could be more meaningful to
Meaningful, right,
Washington, okay,
Yeah,
all right.
Doug's got it.
Oh, it's Doug, got it, okay.
Yeah, I totally agree with Eileen that like we care about what the drugs that are important to Washingtonians. And I think that Ryan's spot on the all payers claims database will allow us to see that. I also think that like, just going back to which types of plans we can regulate question, which I know you're probably getting bored of me talking about this, but let's just imagine that like everyone, or let's say like 99% of people with MS in Washington have a type of plan that we can't regulate. Then would it be worth it for us to prioritize those drugs? Maybe not. Alternatively, like maybe we can regulate. Maybe the plans that we can regulate include a lot of people who have I don't know, some condition that is really common. Then maybe but it doesn't. It wouldn't rise to the top otherwise if we looked at all plans together. So that's why I think it's important to consider, who's in these plans, which plans we can regulate, and who is in those plans.
Oh, and then to add to that, the socioeconomic portion of this, right? Because, yeah, we can see what's eligible, but then, what percentage of the population needs these drugs but can't afford it, so they're not on it. So it doesn't look like on the total claim data, you're not gonna see a high amount of it just because people can't afford to get on. But when you look at the disease itself, I mean, you might have a fairly high number of people that is needing it.
Further questions, comments? We're ready for, I think for, public comment at this point.
Oh, sorry, I have one more slide.
Oh, you do? I'm sorry. I just went right over that.
Good job for keeping us on track,
Yeah.
Kelly.
All right, so really quickly, next steps as we move along in the process. As I mentioned, in the next meeting, we'll dive into deeper detail on the potential data measures. And in the coming meetings, the board will be choosing which data measures they want to use to select the drugs for affordability review. And then the board will also be developing the methodology. So as I mentioned, the whole ranking and weighting thing on based on information from these data measures and how they'll be used to select drugs for affordability review. And then we heard your idea from last time, and we'll be creating a dashboard similar to Colorado's that shows the eligible drugs and the data measures that the board chooses. All right, yeah, so that's it from me, and we can move on to public comment.
I have one other thing that I just wanted to mention as we go forward. And when do you anticipate that I think like the selection of therapeutic alternatives will be important, and we know that'll be difficult. Is that part of this next step for the selection, or the selection of drugs for affordability review, or is that part of the affordability review? I can't remember.
When we're doing the affordability review, that's one of the things that we need to consider.
Okay.
For the selection of the drug, yes, for the selection of the drug, yes.
Equivalent.
But we're not gonna be selecting the drug here for a while. So we still.
Okay. Yeah, I just wanted to point out there's some modern academic literature on exactly that topic, the selection sort of defining therapeutic alternatives. A lot of people are looking at it in the context of the Inflation Reduction Act, and so in the same way that the portal has those white papers that we can follow for a lot of this stuff, for a lot of these methodological issues. I have some papers that I would recommend for us for that step. So whenever you're ready, I can send them over.
That'd be great.
Yeah.
Very helpful. Has anyone signed up?
I do see some other raised hands in the Zoom.
Yeah.
So I'll open up share a timer, and then we can maybe start with the folks in the room and then move online. So in the room, it was Curtis, right? Ready?
Thank you, Madam Chair and board members. I'm Curtis Knapp with Life Science Washington. We represent the full continuum of organizations that help deliver new therapies to Washington State residents. That includes local biotechs led by scientists, doctors, and entrepreneurs who spend upwards of a decade and hundreds of millions of dollars to develop a new therapy without bringing in revenue. Academics, nonprofit research institutes that conduct clinical trials, and companies that manufacture drugs right here in Washington State. And of course, our leading cancer centers that provide top-tier cancer care to Washington residents. And all of this has allowed our state to become a top 10 destination for life science innovation, and we're really proud of that. And that's made us a leader in next generation therapies like gene and cell therapy. And we've seen how in other states they're struggling with some unanswered questions about how upper payment limits are going to maintain access for patients. We've seen states select a drug only to reverse course once patients have pointed out that would cause them to lose access to important medicines. Oncologists have testified that upper payment limits could force them to use less effective, more toxic medicines, and that just increases hospitalization costs. We've seen pharmacists note how upper payment limits set prices for payers and purchasers, but not manufacturers, risking pharmacists and hospitals' ability to provide important medications. And one of our member companies modeled a theoretical upper payment limit on a cancer therapy developed, invented, and manufactured right here in Washington State. And they concluded that that could cause them to have to pull it from the Washington market due to national supply chain dynamics. And as we all know, as you all know, the reality is that pricing is complex and each step of the supply chain affects the treatment costs. So we implore you to consider decisions by PBMs, pharmacists, insurers, hospitals on the availability of medicine to a patient. And that's important because payments to those entities are often greater than payments to the entity that actually invented that medicine. And, you know, recalling back to the portal presentation, we also encourage the board to articulate the primary purpose of the PDAB. Is it to manage patient costs to help systems save money, or something else? And so to be effective, we encourage advisory boards to include voices of those who have experience in that complexity of pricing. And although we know the industry is limited to one member, we encourage collaboration and creativity to maximize industry input. And importantly, affordability reviews should seek to directly lower cost of patients taking the medicine being reviewed. And you know, the bottom line for us as Life Science Washington is we want to make sure that local companies can continue delivering innovative medicines to patients, invented right here and used by residents right here. Perfect timing.
Thank you.
Is there anyone else in the room who wants to speak? No? Okay. So we'll go. Just going down the list in the order that it's presented. So Daria McGrew, I'll unmute you and then share the timer.
Thank you. Confirming you can hear me.
Yep. Go ahead.
Awesome. Thank you so much, Daria McGrew, on behalf of the Pharmaceutical Research and Manufacturers of America, or PhRMA. Thank you for the deep discussion today and all the incredible staff work that has gone into this so far. And thank you also for some of the additional descriptions and clarifications that have been added to your work in the last couple of iterations. Given the breadth and detail of today's meeting materials, we wanted to take time to write in-depth feedback. So we have not submitted a letter for this meeting yet, but we will be submitting written comments in the near future. Additionally, it is much easier for stakeholders to provide constructive feedback on written policy, as you've begun to put this out in written policy, rather than slide deck presentations, and ask that you continue to publish this as written policy as you move along the process. At a high level, a couple of things I want to point out today. There are still inconsistencies in how you're identifying drugs at different steps. For example, you say a drug is a distinct NDC, but then in the very next line, you say, when it comes to 7 years on the market, it means a drug ingredient that has been on the market for 7 years. And later, I believe you have proposed rolling up multiple drugs in a class into a single drug. So these are, all of these are inconsistent with each other. And we urge you to reconcile these in a consistent definition of drug throughout your process. As you move into your identification of specific eligible drugs and publication of that, I want to reiterate previous requests that you build into your policies a timeline for stakeholders to provide feedback or questions about the data. This is complex, detailed, large data sets here. And we have seen in other states, there have been errors in the data that later need to be corrected. And sometimes they have to go back several steps if it's not caught in the first few rounds. So we ask that you publish these materials. Thank you for saying there would be a dashboard. I appreciate that. We ask that you publish these materials in a time that is sufficient for manufacturers to review and provide feedback before any votes are taken. We will have more detailed comments forthcoming, as I said, and again, thank you. Want to commend you for considered and detailed conversations at these meetings and as you continue to do this work. Thank you.
Thank you. Simon, do we have others? One more?
Yeah.
Okay.
I see Colette. Unmuted you.
Did you folks want me to speak?
Wait, it looks like you had your hand raised. You don't have to speak, but I just want to give you an opportunity. That's why you raised your hand.
Okay, I wrote my question. Does this, I'm a retired employee, state employee, and I'm a PEB member. Does this board have jurisdiction over PEB, retiree, UMP, and Medicare supplement plans F and G? It's a rather simple question, but I'm not clear.
So Elliot, thank you for the question. This is Ryan. We'll do some research and see exactly how do the upper payment limits apply, because it says to plans offered under 4105, which, as you may be aware, is the PEB and SEB programs. So I think we would need to just double check on how this board may impact 4105.
Thank you, and I miss you at PEB meetings.
I'll be at a PEB board meeting next month.
Oh, that's wonderful. Thank you.
I don't see any other hands raised. Anyone else want to speak? Feel free to use the hand raise function on Zoom.
Ronnie, sure. Oh, there you go.
Okay, I'm unmuting you, Ronnie, and I'm just gonna share the timer. All right, go ahead whenever you're ready.
Thank you. So I just wanted to comment on the fact that, the reports that we've heard about Colorado's legal cases or barriers to completing their prescription drug affordability work, and it's simply that we do need to include the pharmaceutical manufacturers in this process. So it's really good to hear public comment from them and to hear board members looking to involve them. We know that one of the barriers with costs, or one of the reasons for cost, is that pharmaceutical manufacturers are not transparent in how they're spending their money. It's frightening to hear that they're spending money on lawyers to sue a board instead of on working closely with the board to find answers. The pharmaceutical companies want to provide the best care that they can. So I optimistically believe that, they're not on a different side. We're all on the same side trying to provide the best care. But just hearing or knowing the lack of transparency and hearing that they're suing a PDAB instead of working to find the best answers kind of frightens me. And it goes along with my experience with drug companies. I am a retired pharmacist and have worked with advertising and with non-transparent actions by drug companies. And there are answers there and they are willing to work with us. So it's good to hear that that's available. And I just wanted to share my almost pain in watching the money that's spent on TV commercials for drugs, for rarely used drugs. And it just seems like the money could be spent on evaluating efficacy or decreasing side effects. I think we have a great ally in the pharmaceutical manufacturers, and I look forward to this board including them in future discussions. So thanks for the opportunity to share that.
Thank you. Yeah, anybody else?
Any other comments? Online or in person? Okay. Seeing none.
All right, well, I think our work is done here. Thank you. And we'll see you at our next meeting, which remind me.
July 16th? 30th?
I thought it was 30. All right, we'll double check.
Ivan, what was it again?
That's better for you.
That's
better.
Yeah, 16.
July 16th. Yeah, that sounds good.
Yes, that's right.
Had me worried there for a second.
All right, well, thank you.
Sorry, 30th is healthcare cost transparency.
Okay.
Get something. Right.
Do that. I'm gonna be in the same room.